And let me know when.
Meeting is being recorded.
Good to go.
All right, thank you. Good morning, everyone. Welcome to the Board of Behavioral Sciences, the Telehealth Committee meeting. Today is March 29th. Well, actually, it's March 26th, 2021, and the time now is 9:05 a.m. And this meeting is occurring at various locations, pursuant to Executive Order N2520, dated March 12, 2020. This public meeting will be held via a WebEx platform. So good morning, moderator. At this time, would you please explain to the public, how the public comment section will be held?
Absolutely. This is the moderator for our public comments today. We will be using the question and answer feature in WebEx. And to utilize that, you will locate the Q&A icon on your screen, which looks like a question mark inside of a square. When you click on that, it will open a text box where you will type in, "I would like to make a comment," and then submit that to all panelists. I will be taking requests for comment in the order that they are received. Today, we will have about a 3-minute time limit on comments. And if you choose to make more than one comment, just know that I will not come back to you until I have gotten through everybody who has had their first request responded to. Then we will cycle back as time permits. And with that, I will turn it back over to Christina.
Thank you very much. So at this time, can I have Christina to help us establish a quorum?
Good morning. Christina Wong.
Here.
Susan Friedman.
Here.
Chris Jones. Chris.
We can't hear you.
Here.
Chris Jones.
Here.
Hi.
You hear me?
And we have a quorum.
Thank you so much. So I would like to move to have the staff and the board members introduce ourselves. So when I call your name, would you please introduce yourself? So I'm Christina Wong. I'm an LCSW member, also the chair of this committee. And next is Susan.
And I am a public member.
And Chris.
I'm the LEP member.
And Roseanne.
Roseanne Helms. I'm the legislative manager for the board.
And let's see, Steve.
Hi, Steve Sodergren, the executive officer of the board.
Christy.
Hi, Christy Berger, regulatory analyst for the board.
Sabina.
Sabina Knight, legal counsel for the board.
And Christina.
Hello, Christina Kitamura, administrative analyst for the board.
Thank you very much. Let's see, can we do, do we need to do public or can we? No? Okay. All right. It will be fine. Okay. So I will move to the next agenda item, which is the consent calendar. And it's about the discussion and possible approval of January 22nd, 2021 committee meeting minutes. So any of the question about the consent calendar? I don't see any. And so I guess we will just need a vote. We'll need to have a motion to approve the minutes. So can I have a motion, please?
I'll make the motion to approve the minutes from January 22nd.
Okay, so Susan move out, I'll second. So any other comment?
And public comment after board comment. This is Sabina, sorry.
Okay, so we need to open to the public comments. Any public comments?
This is the moderator. I'm displaying on the screen instructions for using our Q&A feature. Again, if you'd like to make a public comment, please click on the Q&A icon on your screen, type "I would like to make a comment" into the text field, and submit that to all panelists. And at this time, I'm not seeing any requests.
Nice. So I guess that's Christina. We can have a board vote.
Okay. Susan Friedman.
Aye.
Chris Jones. Christina Wong,
Yes.
motion carries.
Thank you very much. And then the next agenda item is the review of let's see, it's the review of the first telehealth committee meeting and overview of the committee's role and tasks. And I believe it's Roseanne.
It is. So good morning, everyone. This is just a brief overview that I wanted to include in your packet, just kind of summarizing what we did at the last telehealth committee meeting that was on January 22nd, a couple months ago now. This committee has been established to talk about a lot of the outstanding issues related to telehealth. It's a fast emerging field. The committee will meet about quarterly to kind of work through some of the topics it identified at its last meeting. So in the meeting materials and attachment A on this item, just for your future reference, is a list of topics we presented at the last meeting. We had a discussion about areas of telehealth that need to be tackled. I added a couple of topics that were suggested at the last meeting since we had that discussion. At the last meeting, we also looked at the laws of several other states that pertain to telehealth. You'll see that later in your packet. We'll get to that a little bit later today. And also you will see as attachment B here in this item, the current board telehealth regulations. And then there's a proposed change that we discussed last meeting. So we'll just kind of carry this document moving forward so we can continue to reference it at each meeting. That's all I have on this item.
So board member, any discussion? No discussion from the board member? I don't see any hands. And so,
I have something to ask.
yes.
I mean, one of these things on the list of the things that we made that we had to discuss, to me, is really like urgent. But I should have brought it up a long time ago. Obviously, I couldn't wait till this meeting. I thought I had to wait till this meeting, which was wrong. So what do we do about taking these things out of order? Or can't we take these things out of order? I mean, they're in a list, like.
Susan, this is Sabina. I don't think the list is meant as an order. I think it's just as a compilation of what the committee has gathered as topics to eventually discuss and address. So, there's a lot of things on the list, right? So,
Right. So in other words, on the agenda for today, it has number 10 is suggestions for future agenda items. So at that point, can I say, okay, I think number 7 is the one that we should put first on our agenda next?
Can I chime in just a little bit? Susan, yeah, I mean, you could do that. That's fine too. Yeah, just to give you just kind of an overview of what we were trying to do is we have that list. There's so much to talk about in this committee. What we're really looking at on the agenda items as we're putting them on are things that we can actually probably move on fairly quickly. And so a lot of those ones that we haven't put on the agenda today might be ones that are going to require greater discussions. But yes, you can always, during that agenda items, future agenda items, definitely note that for us so we can look at that.
Okay, so after today, are we finished with the things that we can do quickly or not?
We hope so, but there might be additional discussion. So that's why definitely you can always, during that future agenda items or reach out to us too and talk about that. So,
okay.
Yeah.
Thank you.
Sure, no problem.
Well, and this is also, the board members' comment section. So, Susan, if you feel like that, that certain item, in your opinion, you need to, push it forward. I think you can say we just cannot vote on it, and I think, Susan, the items that you want to discuss is already, on the, the list. So, I think staff can certainly, take your opinion into consideration. We just cannot take vote. So, yeah.
Okay, thank you.
And this is Sabina. I just wanted to add one more thing. during the later agenda item for items for future potential agenda items doesn't mean that if anybody states it, it doesn't mean it automatically gets on the agenda. Some things that Roseanne, Steve, and Christy have to put on the agenda next time. Other things might bubble to the top in between now and the next meeting. So I just don't want to, I want to make sure that, feelings aren't hurt or they're not intentionally passing over any suggested future items. They're, merely suggestions at that point. And as Steve said, a lot of the items that we're working on will continue to have to be brought back to the committee over a period of time. And sometimes we just can't add new work, in such a short period of time.
I understand that, but I don't want to find our board looking like with the legislature saying, how could you not have thought of talking about that? I mean, and you have a telehealth committee. How did you not consider that? So I'm just thinking that way. And I understand you're thinking about the nuts and bolts of the things that have gone on for years and years and years in one particular way. And now they're changing because of COVID. And I understand that, but there are issues happening out there in our world because of COVID that we are definitely going to have to address.
Yes. I think this is definitely, that's, Susan, I think the list is, one of your, the suggestion that you put forth is on the agenda. It's about the timing. And so, I really encourage you to speak with Steve afterwards and, and continue to just express concern and bring some information, for the staff to, do research and prepare. And I think that is an absolutely appropriate thing for the board members to do.
Okay.
Thank you so much, Susan. And so at this point, let me open up for the public comments and see if there's any, comments for item 4.
This is the moderator. We've again opened the Q&A panel. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to all panelists. We will now take a brief pause to allow time for those submissions. And seeing no requests, would you like me to close the panel?
Yes, please. Thank you so much, moderator. Did somebody just speak? Oh, okay. All right. Very well. So let's, in that sense, since there is no vote involved, in this, in this agenda item, then we will move to the agenda number 5, and that is the discussion of telehealth law for associates and trainees. And Roseanne, take it away.
Yes. So, and Susan actually brought up a really good point. There's so many topics regarding telehealth. I mean, it's just such an emerging issue, and there's so many things to consider. Some of the things we're going to be considering today, and this item is one of them, are things that the COVID state of emergency have really highlighted in terms of deficient areas in our law. There's several areas in our law where we weren't really getting a lot of questions regarding telehealth before COVID. A few, but not as much. And then when COVID happened, it actually, I think, was a good thing in that it shined a light on some of these areas that are emerging and really need to be addressed. So this is one of the big ones right here, is the discussion of telehealth laws as it pertains to associates and trainees. Because what we had happen is trainees mostly working in on-site situations, and then all of a sudden everybody went to working via telehealth. So a common question that we get now is whether our trainees and associates are permitted to provide services to clients via telehealth. And just because we have a lot of new board members and a lot of stakeholders, I just want to clarify because it can be really confusing. Associates are individuals who have graduated from their master's degree program and they're registered with the board as an associate to gain their required supervised experience hours. So that's what I mean when I say an associate. It can be an MFT associate, an LCSW associate, or a PCC associate. Trainees are individuals who are still in school. They're still in their master's degree program. They have not graduated yet, and they're not registered with the board in any way. They're under the jurisdiction of their school. So for the MFT and LPCC profession, they call those individuals that are still in their master's program doing their practicum and things like that, they call them trainees. The social work profession, however, calls those individuals interns. So I just wanted to point that out because it gets really confusing. So that's moving forward what the discussion is going to, the terms that we're going to use. So let me talk about associates in telehealth first. Marriage and family therapists, associates, and trainees are both explicitly in the law permitted to perform services via telehealth. Their law is the most explicit. Business and Professions Code 4980.43.3I says right straight up, an associate or a trainee may provide services via telehealth. It's in the scope of their practice. So it's great that the MFT law says that, but the LCSW and LPCC law doesn't say that. It's silent about the matter. I will tell you that associates, clinical social workers, and associate professional clinical counselors are permitted to perform services via telehealth because of something that's in Business and Professions Code section 2290.5, but it's really subtle. If you didn't know about the law in depth, you wouldn't know why that is. Business and Professions Code section 2290.5 is the basically healing arts telehealth basic statute. And that statute defines a healthcare provider as any person who is licensed under this division. And then it also goes on to specifically point out that associate marriage and family therapists and trainees can do telehealth and some other professions. But the fact that it says anyone who's licensed under this division automatically includes associate social workers and associate professional clinical counselors. And that's because even though they're not licensees, they're registrants. There is another code in the Business and Professions Code, section 23.8, that says whenever licensees are referred to in the Business and Professions Code, the term also includes registrants. So that is how our ASW and APCC, Associate Professional Clinical Counselor registrants, can perform services via telehealth. But, you know, unless you're me, or Sabina, or somebody that works with the board's licensing law every day, it's not obvious. So we get that question all the time. Due to that confusion, the board is pursuing an amendment in this year's omnibus bill. It already was discussed and approved last year. The board would like to list in the definitions in 2290.5 ASWs and APCCs along with MFT associates. So that's kind of where everything stands on associates and telehealth, is that piece of confusion is hopefully getting taken care of this year, and that will be a little bit clearer. So with that being said, I'll move on to trainees, which is a lot less clear. The law does not specifically address whether social work interns and professional clinical counselor trainees can provide services via telehealth. It's completely silent on the matter. They're not really, they're presumably not included in the definition of a licensee like we just talked about in Business and Professions Code section 23.8, because they're not in any way registered with the board like a registrant is or an associate is. So they're not regulated by the board yet. So the law really doesn't say, except for MFT's trainees where it's explicitly stated. But MFT trainees are a little bit different than social work interns and professional clinical counselor trainees, because MFT trainees are permitted to count some pre-degree hours. And because they can count some pre-degree hours where the other professions can't, they are subject to a little bit more stringent supervision requirements. Even though they're not under the jurisdiction of the board yet, they have to use a board acceptable supervisor. And what I mean by that is that the supervisor has to meet the board's qualifications to supervise. So there's some certain standards. They have to have been a supervisor for a certain amount of time. They have to follow certain requirements regarding settings and things like that. So the committee might wish to discuss today whether or not social work interns and professional clinical counselor trainees should also be explicitly permitted to perform the services via telehealth or not. Is that something that the board thinks should be allowed? Also in today's discussion, there's a couple of other areas that kind of fit into this that if we're going to be doing some clarifying, that these areas also are sources of confusion. One of those things has to do with practicum and the face-to-face requirement. LMFT and LPCC trainees are required to have face-to-face practicum hours in order to, when they're gaining their degree toward licensure. The requirement is in several sections of the degree of the MFT and LPCC statute for both in-state and out-of-state applicants. There's also a reference to that requirement for older degrees, degrees that were gained or started prior to 2012 and they had to have been completed by 2018. So if a change is made, I don't think it makes as much sense to make a change there because the degree is already gained. But that's another issue that needs to be discussed because we do get a lot of questions about that. And then finally, LCSWs don't have any face-to-face practicum requirements explicitly in their law. They've got an accrediting agency that sort of handles that. But there is a similar language in LCSW experience hours that has caused confusion during COVID. ASWs are required by law to attain at least 750 face-to-face individual or group psychotherapy hours in the context of clinical social work services. So the committee might wish to discuss clarifying whether face-to-face hours must be in person. Can they all be via telehealth or should it be some combination of the two? So those are the three areas of discussion that I would suggest for today. Again, should social work interns and PCC trainees be explicitly permitted to perform services via telehealth? That's number one. Number two, possibly clarifying the face-to-face practicum experience hours for LMFT and LPCC degree programs. And then number three, for ASWs, clarifying the 750 face-to-face hour requirement and what exactly does that mean. With that being said, I will open it up for discussion.
Thank you so much, Roseanne. And this is a very, systematic and clear discussion, I mean, the information being presented, so that, we're very clear about, the kind of the inconsistency, among, all these associates and trainees and, and how the law, actually, really shows, some of the gap. So, so let's really, maybe we can do, the discussion number one, about whether, the trainees and interns be permitted, to perform, telehealth, like the MFT trainees. So, what do you all think? So board members, this is the time for board members to, to share their opinions. Chris, go ahead. And then Chris and then Susan.
I've always been a proponent of equity, amongst the licensees. So if the MFT trainees are permitted at this point to do telehealth, then I think that, that it would be important to consider allowing the other trainees to also do telehealth. I would just like to, make sure that we have some sort of, parameter or working definition as to what that means for them with regards to how that's being supervised. I would also like to get input from the social workers to see how they feel about that. If they're against it, then I would clearly want to step back from that. But it's just a thought.
So, since Chris, you want to have the input from the social worker, and I am one, and I can probably speak for that. I think, if we're just black and white and talking about yes or no, I think definitely it will be a yes, and yet, my concern really is about how much, because, I think a lot of the training, really should not be entirely, up for just telehealth. Because then it becomes very concerning for me. If we meeting like this and we always say, but it's just not the same, then I think this is a very good indicator that, telehealth is not a complete, telehealth is only one venue, one way to provide services, but not really the entirety, of, representing, how all the mental health professionals should be trained. But that's a different question. So I give Chris, I follow up on your question. So yes. And then Susan.
Okay, I think as far as changing the way the law is written, that it should be that if the Institute for Trainees, if the institution at which they are attending school is following the rules for COVID, then they should be allowed to do telehealth. But if the institution has said, okay, the pandemic is over, classes resume, then they should be doing telehealth. They should be practicing the way they normally would practice. But I think this is very complicated because some people may not have Wi-Fi. They may not have the minutes on their phone, for example. So there are other questions that are involved here. And what do you do then? Or do we separate out those questions and say, okay, we're just talking about whether they should be allowed to do this. The question about whether the clients have Wi-Fi and whether they have enough minutes and where they can go to do that is a separate thing. Is that what you're saying?
Yeah, I hear what you're saying. And I think, Susan, what you brought up is definitely, an equity issue, that we know that, telehealth platform, definitely, shows some of those, and I think, for now, we really also are looking beyond, COVID and, and just look at, whether, this particular, training, is going to be, that kind of like telehealth training will be allowed. Which I hear you, it seems to me that, you agree with it, but at the same time, it's also, have the, the importance of having the, the direction, from the agency and also from the supervisor. Am I hearing you correctly?
Yes, and I do think, for example, that we have to decide, is telehealth allowed? Because so many people during COVID have gotten used to telehealth and like it better. They don't have to travel. They don't have to look for a parking space. They don't have to worry about being on time. It's easier for them. Some people have gotten quite bored by it or they don't have Wi-Fi or they don't have enough minutes. So it's a problem for them. So there's different categories of people. But as far as saying whether or not they should be allowed to do that, it's a completely separate question. And I guess we really want to answer it with the time. And with the time, of course, they should be allowed to do it because there's no other way to practice. So it should definitely be rewritten.
Chris?
I also think that, we may need to start looking at things from a different perspective. I think the one thing that we've learned from COVID is that telehealth is here to stay. It's not going to go away. So almost maybe shifting our thought process into, is this live? Are we seeing people in person or are we using telehealth? Maybe telehealth is a new modality with which we are now seeing clients. And there should be a focus on training on how to appropriately conduct telehealth sessions versus saying it's got to be one or the other. So, kind of piggybacking off of what you said, Christina, I agree. There's, it shouldn't be all or nothing. You shouldn't get all your hours to telehealth. I think that you have an opportunity to train people in this emerging modality of treatment. So, if we look at it that way, I think it can give us a different direction on how we can effectively both support our trainees and our licensees, but also, protect consumers, making sure that people are walking out there and they know how to do it. If you can jump from having an in-person session with a client in your office and then they leave and then you've got to turn the computer on because you've got a telehealth appointment coming up next. I think if we can, shift our thinking to that mode, then, I think it'll be better for everybody in the.
And I totally agree with you, Chris, and I think this is exactly, the upcoming, discussion, that is, it's all intertwined, and so, but it is a really good point about that. We should really look at it, through the lens of this is a different modality. It is a different, service provision method. And so how do you deliver service? So, and I'm with you. Roseanne.
One thing, kind of in line with Chris's comment that I wanted to bring up, just as an interesting point. Going back to when we looked at the buckets bill a couple of years ago, that was AB 93, where we kind of streamlined some of the categories and made things a little bit more kind of up to the individual on what they got experience on. We did with telehealth, with that bill, we did allow open up telehealth, so we didn't specify a limit on it for associates. And the thought was at that time with the associates, and obviously this is trainees, so it's a little different, but no, we don't really want somebody to get all of their telehealth hours, but hopefully their supervisor will make sure that they're in the end a well-rounded therapist, and that they will kind of use their discretion in what's appropriate for that particular person. So trainees are a little different because they're not registered with the board yet. They don't necessarily have a board approved supervisor, but they are still under the jurisdiction of the school. So the law right now leaves the school a lot of discretion. So maybe it's okay that telehealth is at the school's discretion. Maybe not. That's kind of a point for discussion.
I think the supervisor, really bear a lot of the responsibilities, in supervising these trainees. And, I know I might be jumping moving forward a little too fast. I want to reference back, that little article that, that Roseanne published, proposed, for us to reference. It is really interesting that, the concern, about, how appropriate, honestly, telehealth it is even for trainees, because, they don't have that experience, and yet, the MFT, trainees already, allowed. And so, it's almost like, it is kind of, may not be, equitable, if you allow one license type, allow the MFT trainee, and yet you don't allow, the social work interns and, and then, PCC trainees. And so, so I think one is about the equity issue, but then, I think it really, the check and balance, will be heavily, on the supervisor. About the appropriateness, since, those social work interns and the PCC trainees are not really under our jurisdiction anyway. So I think, but they look, and I do understand that supervisor look for our direction. So I think, this is actually really, maybe we need to put into language about, that the social work supervisor or the supervisors, period, should really, assess the, the appropriateness, in order to, allow or not allowed, or how many hours and that kind of stuff. I think the social work supervisor will be in a position, to really assess the appropriateness, for the trainees to, or the social work intern to practice telehealth. And provide, the appropriate level of guidance and supervision. Okay. Roseanne and Steve, you guys are writing things down. So, all right. Well, so, should I actually, maybe let me just open up for the public and hear from the public for now. And then board members, if you want to, comment, we certainly can. So, moderator.
Okay, we have opened the Q&A panel for requests for public comment. I am displaying instructions on the screen for your use. If you'd like to make a comment, please click on the Q&A icon on the screen. Type "I would like to make a comment" into the text field and submit that to all panelists. Our first request for comment comes from Ben Caldwell. Ben, your line is open and you will have 3 minutes.
Good morning. Thank you, committee members. Yeah, this is obviously a very important and timely topic. I appreciate the historical context, Roseanne, about AB 93. I want to add to that just a little bit. In the discussions with other stakeholders around AB 93, we had some kind of parallel conversations about, are we comfortable with telehealth being the way that somebody gains all of their hours for licensure? And some of us in those conversations had this sort of admittedly emotional reaction of, I don't know if it should be everything, but we couldn't point to a reason to not allow it other than sort of this vague discomfort. We couldn't point to any concrete thing that would be accomplished by capping telehealth hours. And I think the same principle applies here. As you all are noting, telehealth is certainly here to stay. There's been some research among psychologists suggesting that even after the pandemic is over, a large majority of psychologists' services are going to continue to be provided via telehealth. And it makes sense for people in their training to get adequate training in that. I'll tell you, as somebody who's been in the academic world for a long time, I share this sort of vague discomfort about, well, maybe it shouldn't be everything. But we also went through this discussion in the world of COAMPT accreditation for graduate programs in marriage and family therapy. And there, COAMPT came to the other conclusion. COAMPT decided, well, if you're providing education, graduate education for MFTs, that at least some part of it, and they didn't specify how much, but at least some part of it has to be in person. You can't do it entirely online. And programs were good about responding to the language of the accreditation standards, and they built in these things like, online programs built in these weekend gatherings at different places around the country. But some of the discussion around that requirement has been the same about what's really being accomplished by requiring a graduate program to gather its students, 1 or 2 weekends a year. Are you really doing anything in person that you couldn't accomplish remotely? And just lastly, to talk about the sort of functions of supervision, I've been teaching CE courses on supervision, including supervision via telehealth. There is little to nothing that you accomplish in supervision in person that you can't accomplish remotely. If you want to talk about live supervision, you can do that remotely. There is a whole established process called remote live supervision.
15 seconds.
Records, all of that stuff can also be done in person as well. So I just appreciate the discussion and would encourage you to consider the reasoning behind and what would be accomplished by limiting telehealth. Thank you.
Our
Thanks.
next,
Thanks, Ben. Yeah, sorry.
it's okay.
Moderator, go ahead.
Our next comment comes from Sierra Smith. And Sierra, your line is open. You'll have 3 minutes.
Good morning, everyone. And I am so appreciative of this discussion as well. I run a nonprofit community counseling center in Los Angeles, centering around marginalized communities. And I agree with everything Ben just said prior to this. I've been looking at this from a client-led perspective in terms of what do the clients want. And I suspect that there is going to be a good percentage of clients who are going to want to remain telehealth for those who do have the technological access to do so, because we have a number of clients who take quite a bit of public transportation, which in Los Angeles can be quite challenging to get there, as well as the fact that in a lot of places parking can be quite challenging. So some of these simple things make it much more accessible for marginalized communities to gain access, and recognizing that the clinicians that we work with, who are a combination of trainees and associates from MFT, PCC, and MSW backgrounds, we're always trying to make sure that they have a broad spectrum of clients that they're working with in general, and we'll continue to do our best to make sure that they have a selection of both in-person and telehealth, but recognize that to a certain extent, we are led by where our clients lead, and taking that framework continues to allow this to be accessible in that way. The last thing I want to point out is living in Los Angeles, telehealth is probably the most environmentally friendly thing that could have happened to this industry in reducing greenhouse gases, use of car, any number of ways. And so there is that benefit, which becomes more and more meaningful as we continue down our global warming path. So thank you all.
Thank you, Sierra. So moderator, any other comments?
We have several lined up. Our next one comes from Stephen Tierney. Stephen, your line is open. You will have 3 minutes.
Thank you. Hi, everyone. Thanks for having this meeting. I'm really glad that this conversation is happening, and I agree with my two colleagues. I teach at a college in San Francisco, and last March, the fact is everybody began to do telehealth, everybody, including licensees, and what the board had to do was to sort of allow for scope of competency not to exist for telehealth, because there wasn't time for everyone to get that. And so we trusted that licensees and supervisors and faculty would quickly get on top of the training that was required and create scope of competence. And so now we have, in fact, some students who have spent their year of practicum all on telehealth. And so a question about scope of competence would be, when things open up in the next few months, are they skilled at seeing people face to face? It's a different thing. And so I think it's important for us to be taking a look at this. And I really appreciate trusting the graduate schools to work with their students, as the two previous folks have said. But I think moving forward, I agree with the colleague who just spoke that as far as we can tell in the Bay Area, people are really enjoying not having to travel and park, as Chairman Wong said in the beginning, not having to park, not having to deal with downtown offices, et cetera. So I think in my own practice, I've asked people about it, because we now, starting this week in San Francisco, come back to the office, and none of them are interested in coming downtown to the office, which makes paying rent kind of a nuisance. But so I think we need to be moving forward. We need to have training and competence in telehealth, because whether we like it or not, I think that's it's at least for part of everybody's practice. That's going to be a reality. I don't think we can roll back to where we were last February. That old reality is just not the case anymore. So I really hope that we allow folks, trainees and associates and licensees to continue to see people via telehealth, and that rather than try to limit it, that we get in front of it and increase the training and competency in that. Thank you.
Our next comment comes from Paul Jenkins. Paul, your line is open. You will have 3 minutes.
Good morning, everybody. I'm a clinician and an educator, and one of the things I've noticed, to keep it very brief, is that yes, there have been many benefits to using telehealth, and those have been discussed already. I want to point out a couple of the limitations that I've noticed in my work. One has been mentioned, and that is limits of access. And this has very much been a socioeconomic issue. So for some people have had a wonderful experience being able to not have to deal with public transportation and all that stuff, but others have had the limitations of their own technology be a hindrance. There are also certain populations that are difficult to reach. For instance, working with children. For my trainees who work in places that focus on working with children, telehealth does not work well. You can't do play therapy or art therapy, all sorts of things. Also working with families, trying to get a whole family into a telehealth environment is very challenging. So I think what I've noticed is that after initial enthusiasm. Well, first there was panic, then there was enthusiasm, and now a year into it, we're getting a lot of burnout and hitting the wall. Live therapy training and experience as well.
Thank you. And our next comment comes from Rebecca Gonzalez. Rebecca, your line is open. You will have 3 minutes.
Thank you. Rebecca Gonzalez from NASW, California. I want to go back to the first question or the first thing in the agenda that Roseanne pointed out, which is I do think it would be helpful if it was more explicit in law that ASWs can perform telehealth services. Going back to the other questions, as far as social work interns, we have always stuck by our belief that that is controlled by the school and the Practicum site, and we don't want to have, we keep social work interns out of the law in general. And the last part, I think I agree with the comments people made. Telehealth is here just to stay. It's really hard to put an hours requirement on it because it's always going to be, it's just like a number that we pull out that really isn't based on anything. But and of course, during COVID, we can only use telehealth. But during regular times, I do think that there is some. It is good to say that it could be both. That it doesn't have to be all face to face, but putting an hours requirement on it is very difficult. Thank you.
Thank you. And our next comment comes from Michelle Crawford Morrison. Michelle, your line is open. You will have 3 minutes.
Hi, thanks so much for giving me a chance to share this. I'm also an educator and I've been working with marriage and family therapy and LPCC students for many years. I think all the comments that were made about the benefits and concerns of telehealth are valid. I just want to share that we have had in this last year the opportunity for students to do live supervision in a telehealth platform, so the supervisor can be present. And we have had success training children, families, and couples. So I would say that's not the majority of the clients that come in, but it certainly has been successful. There's a couple of points that I think are also important. And one is that if you're a student trainee and you are doing an online program, for example, and you're in a remote area, having experience in telehealth gives training opportunities that you might not get otherwise. And although California has a lot bigger metropolitan areas than we do remote areas, there are still people out there. And the other thing I would like to add to the conversation, I think it was shared earlier, is that if the committee were to decide that in-person hours are required in order to get licensed, I think it would provide a lot of flexibility to have that requirement as part of the total 3,000 hours of experience before licensure rather than part of the degree program. And one of the reasons I think that is that there are other types of experiences that we want the trainee or the associate/trainee to have, which would be for a marriage and family therapist, they need at least 500 hours in child, family, and couple therapy, but that does not have to be earned in the degree program. I would propose that maybe telehealth would be in the same category. That's it. Thanks so very much.
Thank you. And our last request for comment at this point is Jennifer Alley. And Jennifer, your line is open. You also will have 3 minutes.
Good morning, everyone. This is Jennifer Alley with the California Association of Marriage and Family Therapists, CAMFT. And I would, really like to thank the committee and the other members of the public who made comment. This has been a very thoughtful conversation. And my comments are specifically related to, the practicum hours. And we hope that this is just the initial conversation and that we can have additional discussions on this, somewhat clinical issue in the future. CAMP membership is divided into 3 categories on the issue about the practicum hours and the face-to-face requirements. And so, we do think it's an incredibly important discussion, and we'd like to learn more about this issue for our membership because we are divided. As a body, of course, we empathize with, access to care challenges in rural areas. But there are some concerns about a licensed therapist not having any face-to-face experience. And so we do think, the balance is important. And so we think we might want, there might be an interest in getting, additional input from the schools, agencies, supervisors, students. And so the 3 groups where CAMP is divided on this is, one, trainees should be able to get all their hours in telehealth if they want, which would address the access to care issue. And it might be easier for them to to find jobs, especially in rural areas. And then the second group of thought is that trainees should get teletherapy, but not as it's set up now, maybe have a modification to ensure, as others have already said, that there is proper training. And then the third group that thinks that it should be done in person. And so, there's concerns about or risks of a newly licensed person having no in-person experience. And they think that it's important that it's done in person. And so, like I said, our membership is divided. We think this is a good initial conversation. And we just like to see, before making any changes to the practicum, that maybe there's a way that more feedback could be gathered by stakeholders, impacted individuals, and to continue the thoughtful discussions. So that's all I have. Thank you for your time today.
Thank you so much. And I believe this is the last comment, right, moderator?
That was our last one. I will close the panel.
Thank you very much. So this is a very robust discussion, and I think we did touch on, many other aspects. At this point, I'd just like to, remind, everybody that, our board, when we craft these regulations, we have to really bear in mind about, about public protection, which means that it's not just, but also with all different age groups, the older, the younger, and those who have the access to telehealth and those who don't. And so, I also like to actually, before, I pass on to Roseanne, because I really want to kind of seek out what Roseanne's thought is. So I'm also, I supervise, interns, and I do clinical supervision and, line practice, all of this stuff. And so, and I work for the county, and, and I have to say that, that's, not everybody, telehealth is not for everybody. For those who are severely mentally ill, telehealth won't work. The people who have problems with, technology, it won't work. And I think, one of the things that bother me a lot, is that, one of our mandates is really Yeah. So one of our mandates is really to make sure that we're able to protect our children, and the older adults. And how do we actually have the clinicians carry those mandates without the face to face? You can't really see the bruises, on the children's body, without the face to face interaction. And so that's one thing. And the other thing is like, if, like Chris say, if telehealth is one of the modality, and yet, that's, do we really want to, the training, of our interns and our, associate, just know how to do telehealth, but, when they're back, in person, they don't know what to do. And so, I think, we have a lot to, to think about, but the most important thing is like, when we think about these, we have to think about, it's not just about, how wonderful this technology is, it's how this technology are going to be able to be a platform that to protect our public. And so I want to throw it out there, to kind of like, give another, another point for everybody to remember, and that's really the angle, where the board, is charged to do. So I want to pass it to Roseanne. And Roseanne, what do you think, after all this discussion?
Well, it sounds like there's an interest in equity with MFT. So MFTs, trainees are permitted to practice via telehealth with clients. The law says that they don't have any limits. So it sounds like there's an interest in allowing that for the social work interns and the PCC trainees. So I'm thinking maybe a sentence added into the law in 2290.5 that it's permitted. But then I think that the discussion goes to the other areas is that, and we're going to talk about this in later on in the meeting too, but also is there a desire to allow it, but then put some requirements on the face-to-face that maybe it's a mix or something like that. But I know that there's the argument that that's kind of would be arbitrary, but it sounds like what the kind of a first step would be maybe to allow the interns and all interns and trainees say that they're permitted to do telehealth, but then to put some limitations on the practicum for the MFT and PCCs. For social workers, it's up to the school, the accrediting agencies. There's no language about that. But there is the language in the law for ASWs about the face-to-face. So maybe further defining that, a certain amount has to be in person, maybe. That's kind of what I'm thinking is what I'm seeing overall.
Susan, go ahead.
Well, Christina brought up something that really made me think differently about, and Chris, you could probably really answer this because it suddenly occurred to me that for children, first of all, many children probably are talking to a therapist with one of their parents close by or whatever, which is not useful. And secondly, you're right, you can't see any marks or anything on the child. So somehow or other, maybe in the law, it's got to be written that if you're seeing people the age of 16 and under, there must be a commitment to see them in person. You can do telehealth with them, but you must have a commitment to see them in person, either at their home or at some particular location within a close proximity to the time that you speak to them online. Because how are we ever going to know the truth about children?
Well, thanks, Susan. I think that, telehealth definitely have limitations. I think that's really the point, and also the examples that, that I'm giving. Because the other thing also is about the confidentiality, and when you deal with people who have domestic violence situation, how are you be sure that when you provide, those sessions, that there is no repercussion at home and stuff like that. So our duty is really to, to protect the, the consumers. And so, so there's a lot to think about. But at the same time, again, we need to really streamline our question and really focusing on, the discussion that whether trainees and social work interns are okay. It seems to me that Roseanne captured it right. Yes, the general direction is yes, right? And then I think we actually already talked, touch on, the second part of the question, which is about the face-to-face practicum experience hours. And so, and then, if it's a yes, that, the face-to-face, well, we need to, definitely, I think the question will be, whether we need to clarify this, and so I think, in that sense, so I want to make sure that we deal with the, the things in a more organized manner. So let me come back to you, Roseanne. So do you have enough, that, to cover the associates and the trainees?
So I have enough. The associates are already taken care of. The trainees, I have some language in mind to allow the trainees, social work interns and trainees to state more explicit. Although I know Rebecca, I'd want to hear from Rebecca because I know she doesn't want to mention it. But if we don't mention it, then there's a question. So I have some language in mind that just this like MFT language that we would do the same thing for social workers and for PCC trainees.
Yeah,
if
right.
NASW is okay with it. The question I have would be clarifying the face-to-face. It sounds like to clarify that, we might need to say, either have some language that encourage it. I don't know if we want to go as far as just encouraging, but hey, it's encouraged that not everything is, say it more eloquently, that not everything is online, or requiring. Hey, I've seen some states, I think we looked at some states, some of it is a certain amount, half and half. That's arbitrary, but it needs to be in person. Some needs to be in person. So it sounds like that's kind of where we're going. It's just a matter of how we want that to be written. Is there a certain amount? Do we want it to be a suggestion or strongly encouraged? Steve is shaking his head, so I think he has something to say.
Well, no, either we make requirements or we don't. I think I've always been kind of like strongly encouraged in law. It's just extra words within our statutes and regs that I think it just adds more words that can be confusing. So, I mean, either we look at, I think it's way off the discussion here, but I mean, how much oversight do we really want to have within that practicum hours and the education? My opinion is I don't want to, control what the schools do. Telehealth is a modality that's a modality that's coming up. If they're going to be doing their students a disservice if they're not training that, and also a disservice if they're not, training them with like face-to-face, because that's very important also. So, but how I have an influence, or our board has an influence over the schools and such, it's kind of difficult. And I understand the argument. That was a good one with Mr. Jenkins saying that, yeah, you do want those things, so you can go to the administrators and say, this is really important. The board wants this. So I see that argument too. But I don't know. I think the thing about doing suggestions and saying the board thinks it's good to do this in statutes, it's great. I mean, it's nice. It's a friendly thing, but it doesn't really add up to what are we going to do with that? I don't know if that makes sense. I would rather do that stuff in a different format, not in statutes and regulation, in a, let's put out a statement by the board on telehealth saying that this is what we believe is something that should be addressed, or something to that effect. So
thanks, Steve. I'm thinking, since now we're talking about, the real regulations and whatnot. So let's hear from Sabina, and then Chris, I see your hand. Sabina, go ahead.
Thanks. Can you hear me?
Yes.
Oh, okay, great. So like I always say at every committee meeting, the committees always do the heavy lifting. So I think these are great discussions and you guys are doing a lot of the hard work in figuring out where to go and the direction to take it. In light of everything I've heard, and correct me if I'm wrong, I think that perhaps what happens next is Roseanne takes back everything that she's heard, comes back with some suggested edits to the statutes. Remember, we're making changes to the statutes here, not regulations. And, you know, maybe it's coming up with possible clarifying options for, you know, maybe there's a couple options for each, or maybe there's an hour option. Maybe there's, you know, not an hour option when she consults with some of our stakeholders offline. I agree with Steve. We shouldn't be encouraging something. I hate to say it sounds wishy-washy, or I don't know how else to say it, but you know, that's and it's, how are you going to enforce that? I mean, it's nothing really we're going to enforce. You know, we can always, depending on what the actual, what the full board ends up with, depending on what the full board ends up with later, you know, we can always figure out what our educational messages are to our licensees and our schools and our supervisors. So I think at this point, you know, if Roseanne kind of thinks she has enough, and I know she mentioned, I know we looked at other states in the past, you know, she might be able to just put together some kind of, you know, possible language with different options like she's done before, you know, with the intent that's been discussed today, and bring it back to the next meeting.
That sounds really good. And then I also want to add on that, you know, we do have, I mean, this is a committee meeting, and then we normally will, you know, put it through PNA, you know, our policy and advocacy committee meeting, and then go to the full board. So there's so many different opportunities to refine the languages. But this is exactly the purpose of the committee meeting. It's really to have this kind of like the intimate and also, you know, the robust discussion, so that we can gather, you know, everybody's thoughts, you know, and the opinions, you know, and be able to take that into consideration and craft a language, you know, that will, you know, help us to, you know, to deal with this, you know, telehealth issue. So, Chris.
Hi. I agree with Steve. You know, I don't know that we have the, you know, the authority to dictate kind of what the training programs do. But with that being said, I also feel that the trend of the board over the last 10 years has been to address issues that are becoming relevant. So, for example, with the newly passed, you know, 6 hours of suicide assessment and prevention training that we have to go through as licensees, one of the requirements, or one way to get that is through your university training program. So as the trends are changing, I'm wondering if at some point that we as a board are going to require our licensees to get some sort of CEUs in telehealth administration. Whether or not they choose to do that or not, do we need to have training in that? And I think that then that may trickle down to the universities, and as they start doing training in how to do telehealth, because to, you know, all of our you know, our speakers' points, last February, I think there were 10 of us that knew how to do telehealth. And now, you know, we're all being thrown in there, and a lot of us are trying to catch up to, you know, how to appropriately, you know, provide this type of service with benefit to the client, and also protecting consumer health. I mean, protecting consumer protection, and then in addition to making sure that we're, you know, doing right by people. So, you know, as this evolves, I feel like it's more than just a, you know, just a way of administering mental health support. It's almost like its own field, you know, to a point. So I'm wondering if, just, I'm kind of talking off the top of my head, but as the trend moves forward, is that the direction that we go? And maybe that starts to define things for us better as far as what we are asking people to do.
Thanks, Thanks, Chris. Good point. So, Roseanne?
I think that that's a good point, and I also think that Sabina made a really good point that I think at this point we probably need to see some language, even if that's not like a specific. We haven't settled anything, but I can present some options. Maybe an option where we don't do anything. We might have an option with the face. I'm talking about the face-to-face. It sounds like we want to allow. Of course, I will consult the stakeholders, but it sounds like we want to allow the trainees and interns to do telehealth. But with the face-to-face, maybe an option where we leave it as is and there's discretion. Maybe an option where there's some sort of a limitation, and maybe an option where, it's just required, but it's left vague. And then we continue the discussion. I am also hearing a lot of interest in the this requiring some CE along with this about telehealth. So maybe we work that in for one of our next topics because it seems to kind of go along with things. So that would be my suggestion.
Right. And Roseanne, actually, I think the CE, for the telehealth is actually in one of the, suggested items, that
yes,
we talked
it is.
about. Yeah, it really is. So, so I think this is all good. And again, because, this is kind of like a clump of a, issue, they all interface with each other. And, so I think we're trying to kind of tear it apart and deal with it in a more systematic manner. But I think at this point, I agree with you, Roseanne, so if we come up with some options, some language options, then I think we can, continue to refine, those languages and really see that, what the proposals are, then I think it would be easier to move forward, to look at, which one, will sit better. Since we have all angles, from pro telehealth and, and the concerns and stuff. So, again, I want to thank everybody. This is a wonderful discussion. I don't think we need any vote. And so in that sense, yeah, I don't think so. There's nothing really to vote on. So at this point, I want to thank everybody, to give us those wonderful information, for Roseanne and the staff to continue to work on. So let's move to the next agenda item. Let's see, let me close my screen. Okay, I think the next agenda item is the allowance of supervision via video conferencing. Interesting, another
yes. So this kind of leads us into the next sort of natural, this conversation sort of has a flow to it where one thing sort of leads to another. And all of these are interconnected. And all of the three items you see today are all related, and they're all very common topics that we've gotten questions about because of COVID. So the supervision via video conferencing. So there is the question of whether it should continue to be allowed. Right now, it's only allowed. Well, let me back up. In ordinary times, the law says you can only do supervision via video conferencing if you're in an exempt setting. So that's a school, college, university, or an institution that's nonprofit and charitable. And so right now, because of COVID, because everybody had to kind of drop everything and go, I apologize for my cat, really, drop everything and go online, there was a law waiver that talked about, that basically allows supervision to be via video conferencing in any setting. So there's been a lot of questions on whether or not after COVID ends, if that will continue. Also, right now, the law only explicitly permits associates working in an exempt setting to obtain supervision via video conferencing. The board is currently, this year, has already approved and is pursuing an amendment via its setting definition bill that would change the law to instead permit supervisees working in an exempt setting to obtain supervision via video conferencing. So that would clarify that trainees in exempt settings can also receive supervision via video conferencing. So that's in our current bill that we're running this year. So let's see. I've included some research in the packet. It's kind of, we didn't get a lot of questions about supervision via video conferencing before COVID. It wasn't as common as it is now, there's some articles. When I did some research, I found kind of two things. I found some older articles from like 2010 to 2014, and then I found some articles that were just released. And so there's definitely some interesting articles out there. There's kind of problems. I found a really great one, but there was problems with putting it in the meeting materials because of copyright, because it becomes public. So this one it was already public, so I was able to include it. There's others out there if anybody's interested in pursuing this. There's some academic articles that are more copyrighted and behind paywalls and things like that we can't necessarily share. But there is other stuff out here. And then there was an older article about some case examples. But it's just kind of, I would expect some more research to be starting to emerge on this. And then I also included in this a link I thought was really interesting about, there's a company called Motivo that did some research for COVID on what states are allowing for telehealth and what they usually allow for supervision via telehealth. So that's kind of interesting. Another thing that, as we address this issue, needs to be clarified is the face-to-face contact in supervision. We again have that language in there that says basically individual supervision means 1 hour of face-to-face contact between the supervisor and supervisee. What does face-to-face mean? Right now we interpret it loosely, is that it's via video conferencing or in person. Right before COVID, in the Omni bill that never ran, that the board had approved, the board was going to move forward with saying that face-to-face had to be in person. We were pursuing an amendment, but we've pulled that amendment for now because it sounds like that might not be, maybe it still is the way we want to go, but definitely further discussion is warranted. For part of the discussion, I think whether video conferencing should continue only to be permitted in exempt settings or other settings as well, and how much. And then the clarifying of the face-to-face contact.
Thanks very much, Roseanne. I just want to make sure that, whether it was my connection issue, and when Roseanne, there's, some point that I think the audio caught up, but, there's just some technical issues. So, yeah, just want to point that out. So discussion, board members. So we're basically, talking about, supervision now, video conference, whether we should allow, continue. So any thoughts about, this topic and then about the face-to-face contact? I'm looking at Chris. That's so funny. It's like, I'm looking at Chris's screen. So go ahead, Chris. Love to hear from you.
Yeah, I mean, just like Roseanne said, how one issue is going to be flying into the other. I'm not a big fan of absolutes. So I think that a combination of the two. I do believe there should be in-person supervision 100%. I don't think that you can effectively know your supervisee and have the level of relationship and training without having some face-to-face time. But I also believe that some of it can be done, via video conferencing. I don't know what that ratio is. I would prefer most of it to be face-to-face, but that's not the world that we're living in anymore. And I think we need to be open to looking at the effectiveness of being able to provide quality supervision to ensure great training and consumer protection, but also the reality of giving students access to their supervisors. I do like the part of the conversation that we had at the last board meeting about making sure that supervisors have access to files. And I know that may not be relevant here, but as we're crafting this language, making sure that if there's going to be telehealth supervision, but video conferencing supervision, that the supervisors have access to all the information that they need so that they can effectively do their jobs.
Very well said. And so I am, like I say, I am a supervisor. I have to say that, the experience of doing, supervision definitely is different, via, video conferencing versus in person, and my love is doing group supervision. I love group. So, and I have to say that it was very, very challenging, to pick up from in person to being in teleconferencing, because it doesn't allow that spontaneity. The platform itself, the technology doesn't allow that certain dynamic to flow through the screen. And so and also it is also very easy I really resonate with the article. It's very easy that that not everybody is on the same page, and some people will slack behind, and some people will not talk. It's I think especially in a group setting, and since especially we do allow group supervision, I like to point out that it's not easy. It's doable, but will that be the same quality like the in person? Definitely not. Definitely not. And so so my thinking is that again I think the I'm like Chris. That's why he's Chris, I'm Christina, right? Bad joke. But I think I'm also not like an absolute, and I do believe and advocate that that there is certainly a proportion that the face-to-face contact yes, can be via video conferencing, but at the same time I think when we're talking about in person, physically in person, I think that is important to clarify. That's just my take. So and then in terms of exam setting, not exam setting, I was, when I was reading, the material, maybe Roseanne can help me. It's really about the context, why way back when, the video conferencing is only allowed in the exam setting, but not the others.
I don't know the exact reason. It's been that way for a long time. My guess is that maybe it was thought that a little more oversight's needed in settings that are not exempt, kind of the same along the lines of the same extra rules about supervision that we put in private practices. We don't want an associate or a trainee practicing independently. We want the supervisor around, so that's probably the reason. That's my best guess.
So, so this is another set of the language that has existed for a long time, probably even before, the technology is so, so widely used. So that's wonderful. So I think, if you don't remember it, so it's at least 10 plus years old.
At least probably goes back to I'd have to look for sure, but it probably goes back to the 80s or early 90s.
Yeah, right. Okay. So that totally makes sense. So in that sense, there's not like any safety issues and so I think I will feel comfortable, to expand it, to the, all the other settings too. So, again, so let me go back to the board members. Any other discussion about this before I open to the public comments? Susan, go ahead.
Well, I just have one question because I'm not a therapist, but I'm wondering if, you mentioned that there are some people who their entire education has been teleconferencing and telehealth. And I'm wondering, now that the pandemic is coming to an end, really, and probably the governor will have everything open by, I would suspect by maybe May or June. Do we want to say that everyone who has done their entire program via telehealth has to undergo 2 programs, let's say, with face-to-face supervision because everybody has to be knowledgeable that they had to deal with something that was unheard of, that will probably never happen again for another 100 years, we hope. And therefore, they have to make some accommodation for it. And the accommodation would be that they would have to undergo at least 2 or 3 sessions with face-to-face supervision?
I think, Susan, you have a point that, I think the training, it's really important, because, I think, what you're pointing out is that, education wise, you will have this group of students, come to the field, probably only know, a lot of telehealth and, learn their education online. And so how do we guarantee them that, that they're able to, to be competent enough, to perform, these mental health services when they graduated? And so, so I think this is actually really important point too. It's like, I think that, that kind of reiterated the importance of having, that face-to-face supervision, so the supervisor, are going to be able, to provide the training and also the guidance, for the, for this new generation, probably learn everything online. And so, so I think that is, what I'm hearing is that, that the face-to-face in person, the physical in person is actually important. So thanks, Susan. At this point, do I have any public comments? Maybe we'll just open it up. Moderator, please.
This is the moderator. We have opened the Q&A panel for requests for public comment. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to all panelists. Our first comment comes from Ben Caldwell. Ben, your line is open. You will have 3 minutes.
Thank you. Again, appreciate the discussion of this. Ben Caldwell, licensed MFT. Part of the challenge here is that we're all sort of working in something of an information vacuum. We don't really know, comparatively speaking, how effective remote supervision is compared to in-person. I would suggest there's at least the possibility that we're talking about sort of 3 different tiers. There's the physically in-person, there's the two-way real-time video conferencing, which in my mind is still face-to-face, it's just not in person. And then there are other forms of technology-assisted supervision like by phone. Whether those are meaningfully different in their effectiveness and in their safety, we just don't have a lot of data one way or another. I, as a supervisor myself, certainly see the value of that face-to-face interaction, whether it's physically in person or via video conferencing. But I just want to note the parallel of the conversation that we're having here now and a lot of the conversations, if you go back 10, 15, 20 years, about video conference therapy and technology-assisted therapy, where there was a lot of discomfort among professionals about using this new technology, concern about whether it could be safe and effective. And now, today, we have reams and reams of information supporting the idea that video-based therapy is not only as effective as in-person therapy, but actually in some instances can be more effective. So it's worth considering again what specifically is being achieved by a requirement for in-person contact that isn't achieved via video conferencing, assuming that, as Chris was saying, a lot of the other things that we know need to be in place for supervision are in place, like access to records and that kind of thing. So thank you for the discussion, really appreciate it. I don't have a strong opinion one way or another, but I think it's worth at least exploring the specifics of what really are we trying to ensure happens. Thank you.
And then this is exactly why we have this robust discussion, right? It's really to, to hear from the public, and gather, you guys' opinions. So thanks for, sharing your thoughts. I think we can move to the next one, moderator.
Okay, our next one comes from Jennifer Alley. And Jennifer, your line is open. You will have 3 minutes.
Good morning, and thank you again for allowing me to make comment. This is Jennifer Alley with the California Association of Marriage and Family Therapists, and we don't have a formal position regarding, supervision, but we, appreciate the comments made by the board and by Ben and hopefully other stakeholders, because, we pause over the lack of physical oversight, and so we would like to hear from supervisors, associates, and other professionals. We're generally supportive of telesupervision, but really it's just the pause that could, essentially allow for no on-site supervision of associates. And when we think about private practice and that there may be only one clinician, in that practice, that, it does cause us to pause, and so we may want to distinguish a little bit more, in the settings. It might be, a conversation that the committee and the board has, because we want to make sure that we don't set our associates up for failure or for, harm. So again, we don't have a position, but we would like to hear input, and we just want to make sure that, associates aren't too far removed, and to be out there on their own. So that's all I have to say. Thank you again for the opportunity to make public comment on this important issue.
And Jennifer, I want to, thank you for reminding us also about the importance, the setting wise, the private practice, then sometimes, the private practice with the one-on-one, that's definitely, one of the big concern too. And so, and especially, for that side of the law that, if it's been crafted so many years ago, and I think very likely, that, the limitation might be actually focused on the private practice. So I think, Roseanne, we can hear from, everybody, and then we can, talk about, what the possible solution could be. But thanks, Jen. I just want to thank you. Thanks. Moderator, maybe we can move to the next one.
Yep, our next comment comes from Paul Jenkins. Paul, your line is open. You will have 3 minutes.
Hello again. Yeah, this is a wonderful conversation. First, I just want to support Ben and what he was saying, that we're really working in such a brave new world, and there's so much we don't know. So we end up referring to personal experience or clinical experience. So I just want to say, as an educator and as a supervisor of many years, I've noticed a dramatic difference in moderating group conversations in class, in practicum training, and in group supervision between live interaction and the electronic interaction. It really is different, and it's not equivalent. So I do have a very strong concern with the idea of going fully electronic, fully remote on supervision. Partly because what this could set up is, if you have 100% telehealth and 100% remote supervision, now you can easily have a situation where a student lives nowhere near the site. They could be hundreds of miles away, never make direct in-person contact with their employer, with their supervisor, or with their clients. And just that complete disconnect, that complete human disconnect, really concerns me, for all the obvious reasons. I mean, I have a concern with, you were talking about working with folks who are clients who are severely mentally ill. What if I have a client who is communicating suicidal ideation? How am I supposed to do a 5150? How am I supposed to hold them in my office until somebody gets there? I don't even know where they might be. They could be sitting in a Starbucks somewhere. They could be sitting in their car somewhere. There's lots of concerns that go into remote social connection. So again, I don't have a magic answer. I agree with the concern that any number we put on these things is arbitrary. However, I would note that all of our numbers are by necessity arbitrary. 3,000 hours is arbitrary. 5-to-1 and 10-to-1 ratio is arbitrary. We have to come, as human beings working collectively, we have to come up with certain guidelines that will feel arbitrary. We try to guide them by some empirical information.
15 seconds.
Usually we don't have a whole lot of that. Usually we make our best guesses, but we have to have some guidelines, because I also agree with the previous comment that just making suggestions has no teeth. People see, when they read this as a suggestion, what they hear is, I can do whatever I want. That's it.
Yes, we definitely share the concern, and this is also important that, Mr. Jenkins, you as an educator, to share that, your observation. And so, yes, our populations that we serve are very diverse. And, and I do have firsthand information. Yeah, I mean, firsthand experience about like, you cannot do a 5150, involuntary hold, through, telehealth. So there's certainly that, I think, what I'm hearing is that, definitely, is the, the importance of having that in-person contact, that sort of like that supervision, so that, at least the, supervisors are able to, to have that sort of, feedback directly face-to-face with the supervisor. So thank you so much, Mr. Jenkins. And I think we can move to the next one.
All right, our next comment comes from Sierra Smith. Sierra, your line is open and you'll have 3 minutes.
Hi, again, thank you. I appreciate this discussion. Speaking specifically to the notion of telehealth and particularly virtual supervision accounting as face-to-face and how that looks, I would like to ask that the board take into consideration accommodation for people with disabilities. One of the benefits that has come out of the virtual space for supervision is that we have a supervisor who was diagnosed with Parkinson's, who's quite an excellent supervisor and has lots of experience, but the physical limitation of coming back into the space would prevent this person from being able to supervise. And, we would lose them. Additionally, we have some pre-licensed clinicians from time to time who use wheelchairs, and relying on access, which is the public transportation for wheelchairs, has been very challenging. And when it was looking at it from the client-centric perspective regarding the face-to-face for clients, for supervision, I would say that it may be not worth forcing people who have to go through additional challenges to get face-to-face for supervision to do so when it becomes an issue with their health. And as much as I hope it's 10 years till the next pandemic, 100 years, science is saying we're looking at more like 5 to 10, and that this is going to be happening more regularly. So I'm asking for accommodation for people with disabilities to continue with supervision over video, and of course, access to records. We use electronic health records, so they have access to notes. That makes perfect sense. Thank you.
Thank you so much. And moderator, I think we can invite the next one.
Okay, Marianne Callahan is our next commenter. Marianne, your line is open. You will have 3 minutes.
Hi, this is Mariana Callahan, and I run a community mental health center in Los Angeles area. And I just wanted to sort of add the perspective of operations as a clinic that serves the public, particularly people who need low fee services, and also functions as a training center. So one of the most important things to me in being able to provide the best services to the clients is to be able to have the best training experience for the trainees and associates who are working there. And hiring on the best supervisors is the key piece to that for me. So I think one of the things that I don't know what to expect for example, this coming fall, which will be our next training cycle, is I know I'm going to need to do some hiring of some clinical supervisors. And I do know that it would be very helpful to me to have a maximum amount of flexibility in terms of who I can recruit, who I can hire. Sometimes the best person to provide the supervision might not be able to commit to coming to our physical location, but they might be the best supervisor for our needs. So I think it would be very helpful from an organizational perspective to have maximum flexibility in terms of whether or not supervision can be provided remotely or whether it would be mandatory that it be in person on site. For example, we have a supervisor who is our specialist in treating couples, and she does all of the training for couples counseling, which is a very important service, and our trainees want it. And as I believe is happening in a number of other industries, our supervisor moved out of the area. She moved to a different part of the state during the pandemic. So if she's required to be providing her supervision back in person, she will resign. And that's a loss for the organization. So I just wanted to share that perspective as well. I really appreciate this discussion. Thank you.
Thank you so much. And that's a real issue. Yeah, thank you. And I think we can go for the next one, moderator.
Okay, our next commenter is Darlene Davis. Darlene, your line is open with the 3-minute limit. Darlene, can you hear us?
Maybe we can come back to Darlene.
Darlene, can you hear us? I will come back to her. We will move on to Rebecca Gonzalez. Rebecca, your line is open.
Thank you. Rebecca Gonzalez, National Association of Social Workers, California chapter. I also really appreciate this discussion, and I appreciate the last two speakers. I think they brought up really great points about accommodations for people with disabilities, and also about sometimes the best supervisor might not be right there. I do think it's important to open up this possibility to non-exempt settings. But once again, going back to Ben's first comments, being in an information vacuum, it's very hard to put a limit on it. I think we all intuitively feel like some face-to-face is good and necessary. So I don't know whether it's 20% is allowable video conferencing or what that threshold would be. But I do have some of the concerns that Jennifer Alley talked about, that being all remote. But I do think it is important to keep this option open for all settings. Thank you.
Thanks, Rebecca. I think we can have some moderator. You can do your job. I just not telling you what to do.
Not a problem. It's quite all right. I'm going to go to our next commenter of Kathleen Wenger, and we will come back to Darlene. Kathleen, your line is open. You will have 3 minutes.
Okay, can you
We
hear
can.
me? Okay, great. Well, first of all, thank you so much for creating the Telehealth Committee, and I truly appreciate this discussion. As both an educator and clinical supervisor, I would strongly recommend to the board and this committee that moving forward, telehealth supervision be allowed for both trainees and associates. While we know that electronic supervision is different, I have truly found that telehealth supervision to be very effective. It is also my belief that we are better serving and protecting the consumers of California by having supervision easier access to our supervisees, which would be difficult if they're all required to come into the offices and meet with us face to face. One note to the committee is that MFT trainees are enrolled in clinical practicum. And so in addition to clinical supervision at their site, they are meeting with a practicum instructor who is also licensed and getting that face-to-face, although that is not supervision, that oversight of the individuals that are enrolled in school programs. So it is my hope moving forward that we keep it. And I would love it if maybe the committee might poll some of the schools, if there's about 75 MFT programs in the state, to get some feedback on what it's like for them in their training programs. So thank you very much.
Thank you, Kathleen. That's wonderful feedback. And I think moderator, looks like Darlene is back, huh?
We are. She's been working on trying to fix her audio. We're going to give it a shot here. Darlene, you are unmuted. Can you speak?
Can you hear me?
We can hear you. Perfect.
Yes.
You'll have 3 minutes.
Thank you so much. I'm Darlene Davis, Hope Counseling Center Executive Director. the first thing I wanted to say was to just remember that we've all been commenting on what a robust discussion this has been, and we're doing it via telehealth, so or teleconferencing, so it is possible. I wanted to say that this is a transition. This is a transition for all of us, and I think it's a different experience, as Paul Jenkins was saying, but it's not necessarily good or bad. I would love to hear from some of the young people that have had their full school online and have been doing that for a few years, what they are experiencing in supervision. I am also a supervisor, and I feel that it is it is different than in person, you're right, but that comes from my brain knowing what it was like before. And the BBS talks about being progressive and staying on top of the laws. In 10 years from now, the world is going to look completely different, and telehealth is going to be worldwide, as it already is in some ways. So let's see, what else? Oh, that it's not that we're mandating that it's all done by telehealth. It's just that a supervisor could say, you know what, I need to see you in person, come in person. And if we decide to change the law for allowing all the trainees and the ASW or the social worker interns to do telehealth, and then we say you have to do supervision in person, I think there's a lot of parallel processing that goes on in supervision, and so I would like to mirror that. I want to have the experience, I want to offer the experience of doing telehealth with my supervisees if they're doing telehealth with their clients. And I think that was it. Thank you.
Thank you, Darlene. So it looks like, Roseanne, I'm going to be back to you again. So it looks like we have a very good variety of, opinions, so I'm thinking that should we actually, come back to you for, crafting some language and maybe some options, to look at? What do you think?
I think we need to narrow the discussion a little bit about what the options would be. I'm hearing kind of a mix in that I'm hearing that it doesn't sound like we're 100% comfortable with going all in, allowing 100% telehealth. I'm wondering if maybe something that sort of leaves them to discretion but still requires as a first step would look maybe like requiring the majority of time. Well, there's two different ways you could do it. The majority of time with the supervisor be in person and then kind of leaving it to their discretion how they handle it, or saying the majority of putting it up more on the associate or trainee and saying the majority of their overall supervisor contact hours must be in person. So that way, if there's an opportunity for a really great supervisor, but it's only via telehealth, then it's still an option. So I don't know, what are thoughts about those options?
That's why we have you, Roseanne, because you are absolutely right, because you can also kind of bifurcate, the situation into the, experience of telehealth and then versus the teleconferencing supervision,
right.
Yes. Yeah.
So, I mean, those would probably be the two options that I'm leaning toward. I don't know if is that along the lines of the direction. I'm not hearing that we want to prohibit supervision via video conferencing, but I'm not hearing that we want to 100% allow it. And so my inclination is, rather than come up with like an arbitrary 20%, 30%, just say the majority needs to be in person and kind of leave it. Now, the two options would be, is that with each individual supervisor, or is that with supervisor hours in general, to leave a little bit more accommodation for supervisors that have specialties or handicaps or things like that. So those are the two options that come to my mind when I'm hearing all of this.
Right. And I'm hearing that, the same thing too. And this is, and it looks like that, we all, comfortable, I think the supervisors are comfortable in, doing, some of the contact. via teleconferencing. But at the same time, it also, I think there's certainly, different ways that we could do it. And I'm looking at Steve too. It's like he's the one who said, it's important not to be, arbitrary. And so if we say that, this is majority or, up to the discretion of the supervisor, I think, that also not really giving, any very clear direction, what we should be doing. So Steve, what do you think?
My mind goes like a million things, so hopefully I can kind of concentrate on and bring my thoughts to you clearly. I'm almost wanting to bring this discussion back with that video conferencing across, let's say, yes, across all settings, it's good. Now let's bring this conversation back to really have that, it's like the old simple pros and cons. What are the pros and cons? And I think what in my thoughts when I'm going for this, first of all, the other access thing that I'm thinking about too is that, and I don't have the stats yet, but with the population growing older, with the supervisors, we really are going to have a bigger pool of supervisors since our licensee associates are growing. So that's kind of a concern for me. So video conferencing, I think, is definitely going to help out in that. The other thing too is with the arbitrary numbers, we've had all these different numbers in the past. And we talk about public protection. I don't know how that's really, how the numbers have helped with public protection per se. I mean, I think that's where we're kind of at this venture where do we just open the floodgate and say great video conferencing and then see what happens with our enforcement program? I mean, if people are starting to get complaints over people who do not know how to, practice appropriately. I don't know. It's a fine balance. The arbitrary numbers I do not like because I think it adds more constraints on the associates and the supervisors. But at the same time, I mean, I do really see the value. I'm kind of on the same opinion as I think, and I don't know for a fact, but I would think that face-to-face does have, incredible value where you're in the same room. I don't know for a fact though. So I'm thinking bringing this back, saying with the thought of, let's say, video conferencing and supervision is great in all settings. And then maybe just have one more discussion about, are these arbitrary numbers really going to help us, protect the public, or is it going to limit access to the public to, quality mental health? It's kind of that fine line. It's hard to, how do we actually, guarantee that there's going to be quality mental health for the clients? So I think maybe if we can just do one more session on numbers, I guess, and kind of talk about that. Does that make sense?
I think certainly, because I think, telehealth, client receiving services through telehealth, what the quality is, we heard from the provider, but we really didn't hear back, much from the students or even from the consumers. I think that is a very unknown area, and we really are talking about California, being such a, have that variety, of the population, so you're talking about in my Northern California, that people really dying to see people, and yet, Southern California, they like to avoid the traffic, and traffic's never an issue here, and so I think we have a lot of the, the diversity issues, and yet, and then because of that, then the supervisor, whether the video conferencing will do the same thing, will provide that quality of the supervision, that the associate needs in order to get licensed. So we have to almost revisit, it's like, what really is the purpose, of the individual supervision, the group supervision, and so will that be able, through the teleconferencing that, we're able to train them to practice legally and, to practice, in a very competent way, legally and ethically. That's always the question, so, and also, so yeah, Steve, you have another thought?
Oh, yeah, and so, and the other thought I was having during this conversation is too, with the, as you know, the arbitrary numbers, I mean, we have to make them sometime. Really, what we're looking at, and I think what we might consider is looking at, not at an arbitrary number of how many hours, but looking at the supervisor and how they function. Because that's where we can put a number out there, but unless they have an associate or a trainee has a supervisor that is, following best practices, we can't really determine it. I think really I keep focusing on the supervisor because they're the people that are actually going to be training these individuals. And so not necessarily, I don't want to say putting more restrictions on supervision because then people will not want to supervise. But, trying to get to a point where they are understanding, that there might be value in face-to-face instead of just video conferencing. I don't know, kind of focusing instead of on the numbers, but more on what we want supervisors to be doing. Because I think that's kind of, I keep thinking about that because no matter how many numbers we put down there, unless they are getting supervised appropriately, I mean, it doesn't work. So I don't know how that kind of throws the conversation up on this, but I think I kind of focus on that maybe. I don't know.
Roseanne?
I have an idea. Maybe it doesn't sound, it sounds like maybe we don't want to be arbitrary in saying a certain number of hours. We either want to allow it or not. Maybe we would feel better is for the next meeting, what we did is and a couple people brought this up, it's a good point, polling trainees and associates on their thoughts and polling schools and polling supervisors on their thoughts and just bringing the results back on what people's thoughts are on it. Because it'd be interesting to see. And when we did the supervision, when we revamped the supervision law statutes a few years ago, we really left a lot of discretion to the supervisors, and that's kind of the direction that we're heading. So I'm thinking maybe it's okay if we require training on telehealth and supervision via telehealth, and the supervisors know what their responsibilities are, and it's at their discretion, based on the particular individual strengths and weaknesses. If it needs, maybe it's okay to let them make the judgment call if it's in person or not. But let's get that feedback so that we know kind of what the profession's saying after having lived through COVID, and then kind of transitioning back what the thoughts are.
I like that idea because, that also, because in my thought that, we also have a lot of the supervisor, that might be more, they're more seasoned. They're very, very valuable, but also they may not actually be as, tech savvy, as a lot of the people. So if they don't feel comfortable and effective, because this is how the modality we train, right? And so I don't think that, that is going to work, and we cannot just rely on, the people who are very comfortable and then forget those, who actually, don't, they don't feel as competent, to be able to do that. And so, so it sounds like, Roseanne, you're talking about like doing a little survey, to really see, how that is gonna, pan out.
Like we did for the practice setting definitions, we do like our Survey Monkey surveys of the schools, and we'd ask the associations for help in distributing it to the associates and the supervisors, and just kind of see what the pulse is out there, and how people are feeling about it, and then make a decision.
So yes, that's good. So Susan, go ahead.
I think if you were discussing this last March or April, it would be a totally different discussion because then it was required. There was no question about it. No supervisor was going to risk their life to do face-to-face supervision. Am I wrong? So I think discussing it now makes it's a totally different discussion. you know, I think we have to decide what are we making the law about? Are we making it about extraordinary times or ordinary times? And I mean, I like Roseanne's idea about asking opinions of the people who opinions really count. I think that's really important. But I'm listening to other things where I hear about 5150s, about potential suicides, about seeing children, about, you know, about marital problems where two people can't you know, where it's dangerous to discuss it in this kind of a situation. So there's a lot of problems, and I don't really know how you deal with that. I don't know how you make the distinction. Roseanne, I mean, tell me.
There are definitely, I hear what you're saying, Susan. There's definitely a lot of pros. I mean, we can debate the pros and cons all day, and all of them are valid. I mean, on one side, I'm hearing those concerns, and obviously, the supervisor needs to take some discretion if they have, you know, if they are seeing those types of clients where there's types of concerns. They need to know that maybe telehealth isn't the best option. On the other side, I mean, I've heard Sierra Smith brought up a great point about the really great supervisor who has some disabilities and otherwise can't supervise. And supervision is in short supply. And we heard from a guy last time, I can't recall the name of his company off the top, but he's trying to start he's trying to increase diversity in the profession and match students with more diverse supervisors, and allowing supervision via, his point was allowing supervision via telehealth would make that more likely to happen. So there's pros and cons on both sides. I think that the ship is kind of headed toward allowing it.
Right.
So I'm thinking maybe if we do the poll, we can kind of get a better idea on how people are feeling, and then maybe at the same time look at some of the supervision training that we might want to require, you know, as a topic along with these when we're making that final decision. That might make things a little bit better, because it is a big change, and it's scary because, you know, there's not an answer out there. There's some papers about what they think it does, but there's no answer. There's not a concrete, like, this is how it needs to be.
Right.
That's where the struggle is.
I think, you know, as any discussion, you know, this is great that, you know, the more in-depth, you know, we throw the question out there, and now we have the, you know, some of the feedbacks, have the initial thoughts. And it sounds like that, you know, we do need to gather more information. So it looks like that, you know, definitely it is, you know, there is an urgency, you know, what I'm hearing from Susan, you know, and yet we also need to, you know, definitely proceed with caution, and, you know, to have a more well thought out process, a more well-informed process, so we don't have to go back and refix, you know, some unintended consequences. And so, you know, so it sounds like that, Roseanne, that, you know, we will just, you know, go ahead and do the survey, you know, or whatever way that, you know, the staff wants to gather more information, you know, and then go from there, you know, and then we can bring back maybe like, you know, the results and then see how it is. Because I think the good thing is, like, right now, teleconferencing is still allowable. You know, the waiver is still there. And so, you know, I think we can certainly have time, you know, to bring back and, you know, and then we can further discuss it. Sounds good? Yeah. So, so I would like to, you know, take maybe like a quick 5 minutes, some minutes break. So the time now is 11:07. So let's come back at 11:15, and, you know, and then we will resume. Thank you. I am wondering, so since Chris is here, you know, we still have a quorum, right? And so let's go ahead and start the meeting. So welcome back to the Board of Behavioral Sciences Telehealth Committee meeting. The time now is 11:16, and so we are resuming our meeting. And our next agenda item is the discussion about allowable telehealth settings for associates and trainees. And Roseanne, please lead us for another very robust discussion.
Okay, well, I think that I think I might know where we're going with this now that we've kind of, I have a better idea where we're going with this now that we've discussed together too, but we'll go for it anyways. So another question that has come up very frequently with the COVID pandemic has to do about where pre-licensed associates and trainees must be located when they perform services. So for associates, I'll address them first. Can an associate temporarily located in another state practice with clients located in California via telehealth? Can an associate temporarily located in another country practice with clients located in California via telehealth? This is an interesting one that I just recently had. Can an associate temporarily located in another state or country count experience hours for practice with clients located in that other state or country if they follow the rules of the other jurisdiction and happen to have a California licensed supervisor who is there with them who meets the board supervisor requirements? So there's all of these scenarios that have come up increasingly with COVID. For current law, for this, to answer these questions above, the best that we can answer it right now as staff when we get these questions, current law does permit associates to perform services with clients located in California via telehealth. They are only allowed to perform services where their employer permits business to be conducted. So there is discretion to their employer and their supervisor. If it's a private practice, right now the law states that the supervisor must practice at the same site as the associate. However, as we discussed last board meeting, we're currently proposing a bill that would change this to allow an outside supervisor if there is a supervisor agreement in place to access client records. So that might be changing. So based on the questions above, a California associate whose registration number is current and is active is able to practice with clients located in California while the associate is traveling out of the state or out of the country if their supervisor permits it. And their supervisor needs to consider things like the abilities of that person, the associate, the appropriateness of the client, the supervisor's ability to supervise adequately, things like that. However, even if the supervisor allows it, right now the law only permits the supervision via video conferencing if the individual is working in an exempt setting, assuming that we are outside of COVID. So associates that are in all other settings would need to be able to meet with their supervisor in person to satisfy the supervision requirements. So for some settings, it wouldn't be possible because of that if it was a long-term situation. The law does not address a situation where an associate and their supervisor are California licensed and both are practicing out of the state or country together. That's a very complicated situation. We typically, when we get that question as staff, it's rare, but it's less rare now. We typically discourage it due to the interaction with the laws in the other jurisdiction and California laws, and having all of how those might interact. But it's rare for us to even get that question. Usually we would get it more in the question of a military base, and that is considered an exempt setting. So that's the answer to, that's the issue for associates. For trainees, now I'm going to shift my focus to trainees. We get similar types of questions. Can a trainee temporarily located in another state practice with clients located in California via telehealth? We've been getting a lot of this question from schools. And can they gain their required practicum hours for this? Can a trainee temporarily located in another country do the same thing? Can a trainee temporarily located in another state or country do their practicum with clients located in the other state or country if they have a California supervisor who meets the board supervision requirements? So, and what we've been telling schools about that, the law is pretty vague on it. It does permit MFT trainees to perform services with clients in California. It right now doesn't say whether it's permissible for social work interns or PCC trainees. Current law requires all trainees to only perform services where their employer permits businesses to be conducted, and trainees and social work interns are not permitted to practice in a private practice. But other than that, the law appears to leave some discretion to the school about whether a trainee or intern can provide services from a remote location. For MFT and PCC trainees, the law specifically states that the school and the site must coordinate the situation and have an agreement in place that details each party's responsibilities and how supervision will be provided. For social work interns, the law is a little bit less specific than that, but it does say that interns must be performing services as part of their supervised course of study. So right now, only MFT trainees count pre-degree experience hours, so they have a little bit of extra responsibility to make sure that their supervisor meets all of the supervision requirements so they can count those hours. That means an MFT trainee who's not working in an exempt setting must have in-person supervision once the pandemic ends. So when we get this question from schools, which we've been getting it a lot, we have advised schools wanting to allow trainee remote practice and supervision to use caution and to keep in mind that trainees are the newest practitioners and therefore need the most oversight and paying attention to the intent of the law, that the trainee needs to get a quality educational experience, to pay attention to the trainee's ability, the appropriateness for the client, and the supervisor's ability to adequately supervise the trainee. So that's how we address that question right now. And the law does not address anything about out-of-country practicum hours with clients out of country. So that's where we are with that. I'll open it up for discussion.
This is amazing that, that one, it opens up so many different scenarios that we may or may not think about this, and yet it's so important to, to have, to warrant a thorough discussion. So board members, any thoughts about that, Chris or Susan? Chris, go ahead.
It's there's a lot right there. I'm not, it's difficult to follow. I think that at the end of the day, my biggest concern when it comes to, trainees and associates conducting telehealth comes down to the supervision. I mean, when you're working with a client and they're on the other end of the computer screen, I don't know that it matters where they physically are as far as like what services you're providing. I know that there's issues with the legality of the limitations of the license and those sort of things, but I feel like we're diving down a rabbit hole when we're looking at all these different scenarios and what it is that is going to be okay or not okay and under what conditions and this and that. So I'm wondering if there needs to be a different way to look at it instead of where people are physically located, under what conditions are these services being provided and under what supervision are they being provided. I think from and to use Ben Caldwell's phrase, it doesn't really feel right. I don't know why, but it doesn't feel right sometimes when we have an associate providing services outside of our locus of control. So they're traveling to Hawaii on vacation and they're going to do a couple of sessions, out by the pool. I mean, I don't know that that feels okay to me. I don't have a data to support why, other than my clinical gut saying, there should be some parameters that we have in place with regards to how telehealth is provided by our associates. So now that I've opened that can of worms, I will give it back to our esteemed chair.
I don't think it's a can of worms. I think those are very legit question, and the angles that we can explore the situation, and it is very interesting, because, you can also look at like the continuation of care, but at the same time, again, how do you actually, when they move to a temporary location, that they have the support and then they have the resources. They know they can still provide that quality of the services. I think we're not encouraging people to do multitasking, but we're also, by the telehealth, also opening up that, that's a practice that you can do so many things at the same time. Means that, when you can see clients when you're on vacation, you can, you can do all these things. So what really it means to our practice and, and typically and traditionally, how we do mental health and how that impacts our client, most importantly. Right. And so, so not a can of worms. So Chris, good job. So, for myself, I think, it just tag along with exactly, we talked about last time, how much is really how much, and really what is the purpose, I think for the trainee, is a little bit different to me, and then associates, again, I think, it's very important that, since this is, right now the supervisor, takes the responsibility, to approve that. If they're okay, supervisor will back them up. And yet I think they probably need to have language, to put some parameter on, whether it's about the length of time, whether it's totally outright, that we don't encourage that or whatnot. I think for trainee to me is, trainee is a very different ballgame. Because the trainee, it's a very different ballgame. So my initial thought, I know it's not, it's probably hard to put it in language, but I think, the trainees are the one that, has the least experience, so if they don't have that much, they need the training and the supervision the most. And I think they need the least flexibility. That's kind of where my head is going. And so, so I think that's kind of, in a simple way, just to sum up where where my thought is. Any other, Susan, you have any feedback? I want to just make sure that, we got all the board members before, I move to the public comments.
It's really hard to say because I understand that people do move around and they could move, who knows? I mean, if you said it's got to be in the same location every time, that would definitely not work. So I find it very, very difficult to really limit this, but I do think that it should be a professional appearing setting. I mean, it can't be by a swimming pool. It can't be by, the ocean. It can't be. That would be very, very disturbing.
Yeah. And, being respectful to the client's culture, because that's a very important thing. They don't want to see, people with bikini, walking behind the scene, as can be private, it could be, and honestly, even at the house, I get distracted by the dog, just walking back and forth, so that, I think, again, it is very challenging. So thanks, Susan, and thanks, Chris. So let's open the discussion for the public. So moderator, please help us.
We've got it. We have opened the Q&A panel. If you'd like to make a comment, please click on the Q&A icon on your screen, type "I would like to make a comment" into the Ask field, and submit that to all panelists. And our first request for comment comes from Jennifer Alley. Jennifer, your line is open. You'll have 3 minutes.
Good afternoon, almost. It's Jennifer Alley with CAMP. Thank you again for the opportunity to comment, for the thoughtful discussion. I mean, I just really appreciate the background work that the BBS provides for these topics before we have to talk about them. And CAMP, again, doesn't really have a formal position on this. I don't have a lot of answers, but we do have a lot of questions. And so, one of them is, how does the associate ensure that they're complying with the other jurisdictions' laws, right? Which I think is always appropriate when they're practicing outside of California. But more importantly, if they are practicing out of California, whose laws do they follow? For example, record release, child abuse reporting, right? It's my understanding current law is silent on that, and so some clarity would be necessary. know, while most would argue that the California law should be followed, how do we know what the other state laws required, and how will the lack of clarification be remedied? You know, and what if there's a conflict in the law, you know, between the two for the, you know, record release and sharing, or child abuse, or, you know, interaction with family courts and whatnot? And then what is considered temporary? Are we going to define it? Is it going to be defined in other states, which we've seen in other discussions? And so I think that those are just, there's a lot of, you know, worms in the can on this one, that we really need to have some thoughtful, you know, direction for associates and trainees, or anybody really practicing out of state. So that's all I have on this one. Thank you.
Thanks, Jennifer. You know, it's so funny. I was just thinking about, like, you know, I was just thinking about like all the questions you have, and you might, and I was like, you know, okay, when Chris said that, you know, he opened a can of worm, and, you know, then, you know, you bring in more worms, and you said that. It was so funny. But no, I think that was a really, really good question, because it just kind of reminded me way back when we were talking about out of state, you know, not just about the education, but really it's about like, you know, that, you know, all these laws that you have to follow, you know, what, you know, do you have to, you know, follow, you know, let's say you're in Arizona doing, you know, services, you know, then, you know, that, you know, which state that, you know, that you need to follow. And, you know, are you, you know, also, are you practicing out there, you know, kind of like with, you know, not necessarily illegally, but, you know, what will be the state law, the state requirement for mental health practice. So there's a lot of these, you know, this telehealth, I mean, these questions that we have to consider. So thank you, Jen. So moderator, maybe the next one.
Our next comment comes from Darlene Davis. Darlene, you are unmuted and we'll have 3 minutes.
Thank you. Can you hear me?
We can.
Perfect. Yes, this actually came up in our agency, so I think there's a line that needs to be drawn. We had someone that wanted to, or that did buy a house in Hawaii, and is an associate and wanted to do her telehealth in Hawaii. And so we had to come up with a policy, because I think we need to have the option as a supervisor that if I need to see you in person, I need to see you in person. To talk with you. So someone living or staying extended time in another state isn't okay, because I don't have access to you. Secondly, we don't have the time to research all the different states to find out what the laws are in those states. And so we didn't feel comfortable with that either. So we made a policy of 2 weeks. If someone was going somewhere for 2 weeks, we encourage them to take that time off, and self-care is so important, but that if they wanted that continuing of care for their clients, that's important too, but they had to stay in a confidential place that was secure. And I had a third one, and now I can't remember what it was, but those are the two main ones. Was we didn't have access to them, and we didn't have the time or the ability to figure out what all the state laws were. So we said no.
I like that. It's very clear this time. So no. So thanks, Darlene. That is really wonderful. You know, for those who don't know, that Darlene actually has a private practice. And so I think that is a very, you know, important information, that this is the practice that your agents, your business has. So thank you. So moderator, maybe the next one?
Yep, our next comment comes from Marianne Callahan. Marianne, your line is open and you will have 3 minutes.
Hi, thank you. So I just wanted to share that at our training center, you know, we have about 80 associates or trainees, mostly trainees, and we've had all different permutations of this come up. And it's been very complicated, and I think we've dealt with it primarily by just saying no, but I don't know if that's the right thing to do. I think it's just been the easiest thing to do, because all sorts of different scenarios have arisen. I mean, I'm the first one to support people taking vacation. If you're taking vacation, take a vacation. That's it. But last week, I had a trainee who told me that her mother was ill and she needed to go back to her home country. And it was a long distance. She needed to go for several weeks. It wasn't a vacation. She needed to be there, but she didn't want to leave her clients, without their regular therapy. And she was perfectly capable of conducting that therapy from where she was in an appropriate way. She was capable of attending her supervision group in an appropriate way. And, so is that wrong for us to allow that? At the same time, we had another intern who, for family-related reasons, moved back to Fresno, which is about a 4-hour drive from Los Angeles. So she's equally inaccessible physically. She's within the state. So is that different? These are just a lot of different concerns to toss around. And in some ways, it would be easiest if the board or the law just said no, because then we wouldn't have to do all of the considerations and the research. But I'm not sure that's in the best interest of the clients when it is possible to do. And then there's also the issue of malpractice insurance and whether the insurance companies will support services that have been provided outside of the state and that sort of thing. So it gets very complicated.
Right.
Thank you.
Yes. Yes, and and then I think this is wonderful. Yes, it is very complicated, and I'm sure that Roseanne is taking into all these very valuable information too. Thank you so much, Marianne. So let's move to the next comment.
Our next comment comes from Paul Jenkins. Paul, your line is open. You will have 3 minutes.
Hi. Yeah, I'm glad the question of accessibility to the trainee or associate came up, because this dovetails with what I was saying before in the previous section, that access to geographical access to the trainee is important. And as somebody said, being out of state is not necessarily different than being in significantly different parts of the state. We've got students where I am who may live up in the Sierra somewhere. Can they work for an agency that's on the coast in Southern California? Same state, but geographically unavailable. The second issue I had, and this may be an apples and oranges thing, but it occurred to me, so I wanted to put it out there. What if the situation is reversed and it's the client who is temporarily out of state? What if the client goes on vacation to Hawaii and wants to maintain their sessions for a couple of weeks or whatever? How does that change the scenario and the legal issues here? That's it.
Roseanne, go ahead.
I'll answer that. So if the client is out of state, then we simply tell them that they need to check with the laws of that state, because that's more of a jurisdictional issue. Most states consider where the client is located that they have jurisdiction. And so it's based on since it's based on the location of the client. If the other state says they have jurisdiction, whether there, we can't argue with that, essentially.
Mm-hmm.
Well, thank you so much, Paul. That's kind of reiterate, some of the comments, from the previous commenters too. Now we're seeing the trend. Wonderful. So moderator, our next one, maybe?
Yes, we have one more, at least at this time, and this is going to be from Sierra Smith. Sierra, your line is open, and you will have 3 minutes.
Hi, I wanted to reinforce what Marianne Callahan said from Maple Center at Open Paths Counseling Center in Los Angeles. We've run into this a few times. For the most part, we tend to be pretty restrictive with having any clinicians leave anywhere or go anywhere and have them just take that time off. But there have been a few times where what we've ended up doing is having somebody terminate early because of a situation that would have taken them away for a longer period of time, and we didn't feel comfortable with them going away. But it would have been, I don't know that that's always been in the best interest of the client. It was the decision we made because everything was so new and there was so much uncertainty. And so it seemed like just having them go through the process of terminating and transferring that client to somebody who was able to stay in. But it really did impact particularly our clinicians who had family members who, you know, were really struggling and had to go be in other places where they then lost out on their practicum as well. So it's one of those things that's tricky where I think that where you can provide flexibility for the best judgment of the agency or the supervisor, it's helpful because it's not going to be a one size fits all, unfortunately. Thank you.
Thank you so much. Yeah, any other comments? I think this is the last one, right, moderator?
That was the last one, yes. I'll close the panel.
Okay, thank you so much. So, so Roseanne, now I'm going back to you and see what your thoughts are.
Oh, wow. Okay, on this one, I'm going to have to think about it a little bit more. It sounds like maybe we want to leave for I'm hearing that there's some flexibility because I get all kinds of, I get this question at least a couple times a day, but it's all different variations of it. It's never the exact same situation. So I think flexibility to the agencies, maybe it's better to leave, you know, some silence in the law so that there's some discretion on this. I guess I could come up with a couple of options and then report back like the others. One of the options would be doing nothing probably versus, you know, versus having putting some restrictions in. So I could draft something out like that. If that sounds good.
Yeah, I think, you know, it seems to me that, you know, that, you know, that if we don't do anything, you know, so, you know, the flexibility is still there, you know, because of, you know, currently what is being allowed, you know, I think you know, and we're very aware of the fact that, you know, there's still limitations about like, you know, out of state and, you know, like Jen's, you know, very legitimate questions. And those are all the things that, you know, the associates and the supervisor will really have to consider.
Right.
And so, you know, and so there's not like one size fit all, that's for sure. You know, and then I think what I'm hearing about the trainee, you know, it's again, you know, because right now only LMFT, you know, only the MFT trainees are allowed to do that. And so it looks like, you know, that's, you know, the supervisor, you know, like, you know, Darlene's agency, they have different policies, or like, you know, the Maple Counseling Center, you know, they also have a different set of policy. And so it seems that, you know, it's, you know, it seems to me that there's mostly question, you know, for Roseanne to clarify, and yet we're not hearing that, you know, there's any particularly problems per se, that, you know, that this kind of flexibilities that, you know, or this kind of silence of the language is affecting our consumers.
Right.
So that's kind of what I'm feeling. And so, you know, definitely I think one of the options is, you know, no change. You know, that, you know, business continue, right? And the other option is like, how can we also, you know, maybe just clarify, you know, in some form of, you know, languages, and then be able to just like put a little guidance, especially for the out of state, you know, because I think the out of state is a little bit different, you know, than all of the country. No, but then staying within California, you know, just like that, you know, example of traveling to Fresno. And so, you know, so maybe maybe it will be good to maybe just relook at the language and then see if we can, you know, any areas that is, you know, that we can put some highlights and put some clarification, you know, and
yeah, I'll play with the language a little and draft a couple of options, and then we can, you know, you can say if you love it, if you hate it, or maybe there's a middle ground. So I think that's the best.
Right. Susan, go ahead.
Well, I was just thinking when we're talking about this, that it might be if we wrote it from the viewpoint of the client, because it is the client who needs to feel comfortable. It is the client who needs to feel they are getting help and the service that they need. So if the client is amenable, then the person can go to Fresno or India or wherever it is that they have to go. But if the client doesn't feel that it's acceptable, then it doesn't work.
And that's actually, maybe, even like putting in some, like Susan said, maybe it's about the informed consent of services. What do we, what the license, what the trainee or the associate can do, to really inform the clients, and, so that, it's very transparent, but at the same time, also step into like, those kind of like professional boundaries and how much you really want to tell them and that kind of stuff. But I think, that informed consent is really important. That I think that's what Susan said. So, Chris?
I agree that informed consent is important, but I think it's more than just the comfort level of the client, because we're not talking about licensed professionals, we're talking about trainees and associates, people that need supervision. When we lose the locus of control over their supervision, then what happens is that ultimately the supervisor becomes responsible for that treatment. So I think it's just a deeper question than that, Susan. But I agree 100% that there needs to be a comfort level with the client also. But I just think it runs deeper.
You're right.
Yeah. Thank you. So Roseanne, looks like, I think this is good, so I think, we will continue this conversation next time and, and then go from there. Steve, you want to supplement any information?
No, I just keep thinking, I like the Darlene and Marianne talking about, it's really, I'm seeing this, the supervisors are, and I don't know if this is going to be a good term, they're really the board's boots on the ground. I mean, they are the people that are actually helping us to make sure that, everything is being done properly and ethically. And so I like the flexibility of that. And true, we can't ensure that all supervisors are behaving the same way and making sure, telling their associates or trainees that we don't think that's, really appropriate for you. You may not know how to do telehealth right now, or that's not appropriate for that client. Hopefully they will be. I think maybe part of this too is I think what we have the trouble is answering the questions. So what I'm kind of thinking here is, keeping it flexible, but at the same time doing and I don't know what form it would take, educational for the supervisor themselves, or some kind of educational material saying the board, this is what we see, as key points in proper supervision regarding telehealth. And I don't know if like a position paper or something that they can actually review, and leave it in law, generic, but at the same time, making it sure that whatever opinion the board has, we make sure we can voice that moving forward. So.
Sounds good. Sounds good. So not just we need to take care of the trainee, supervisor, clients, we need to take care of the board staff as well. Okay, Roseanne.
Oh yeah. I guess that's it.
I agree with that. I don't know that it's necessarily take care of the board staff, but it's an outreach issue maybe. I mean, we don't typically do a lot of position papers because situations are complex, but it might be something that we look at if we leave the law flexible, it might be something where we have some guidance, about what to consider for the organization, so that when they get these questions, they call us wanting an answer on what they should do, and we give them some factors to consider. It might be helpful to have that on the website so it's more easily accessible, so they don't have to try to find a person at the board that can answer it.
And I think that's outreach, and education is always, important to educate, to educate the change, and give them, some very standard, explanation. So the FAQ, is always the way to go. It just reminds me like that, suicide prevention, I have to, even myself, we supported the law, and now when it comes to implementation, there's still a lot of questions. And so, so I think that FAQ certainly will be the way to go as well, but I think, not having any change. I mean, well, from what I heard, it seems like, there's still, that we can kind of like look at the language and see how we can tighten it up a little bit, but without really completely closing the door. And so I think this warrants, certainly a further examination, about how we want to proceed. So, I guess that, we will hear about this, issue next time, and more discussion is upcoming. So thank you so much. And I think I'm going to move to the last discussion item, which will be it will be Christy, to talk about the discussion and comparison of the range of temporary practice allowances of the other state agencies. And Christy, you're up. And thank you, Roseanne, again. Wonderful. So Christy.
Hi there. Hi, sorry.
Okay.
Just 1 second here.
Yes.
Little technical difficulties here.
You're fine. We can hear you.
Okay, good. I'm glad to hear that. So, actually, can you just give me can I get 5 minutes and come back and finish this item? Can I just get a short, I'm sorry, it kind of caught me a little bit off guard. So I will be, if we can just take a short 5-minute break, I'll be back.
Okay, we can do that.
Christine,
Yes.
If you wanted to move forward with your next agenda topic, you can absolutely do that and just circle back with Christy.
Yes, that's exactly. See, I think great minds think alike. So this is
perfect.
Yeah. So let's move forward to the next agenda item, which is the public comments for items not on the agenda. And so, so let me go to our board members. Any of the public comments for items not on the agenda? Board member goes first. Nope, I don't see anything. Okay, moderator, would you please open the panel?
This is the moderator. We've opened the Q&A panel. If you'd like to make a public comment on any item that was not on today's agenda, please click on the Q&A icon on your screen, type I would like to make a comment into the text field, and submit that to all panelists. Our first comment comes from Darlene Davis. Darlene, your line is open. You will have 3 minutes.
Thank you very much. And just for clarification, I run a nonprofit counseling center. I do have a private practice on the side, but mostly I'm here as a representative of a nonprofit. And I'm not sure if this specific is on our task items, so forgive me, but the part of the telehealth law that says that we actually have to document the physical address, I would like to have a discussion about that. I know we need to confirm it, and I know why it's important. It's important during the session, but documenting an address can be a negative part of a person's treatment record if that was ever to be given out for some reason. So I would like to have some kind of discussion on that actual writing of the physical address in the progress notes.
Thanks, Darlene, for your clarification. Yes, that sometimes, that we just forgot, that, you come, representing the public, as part of our stakeholders. But thank you. So any other comments?
Looks like that's it for the moment.
Great. And then
I will say, I'm sorry, Christina.
Yeah,
on the agenda item, there are several emails that are part of the materials that we got in support of various things related to telehealth, and those are included in the meeting materials as public comment.
Awesome. So, and we don't have to do anything about this, right, Roseanne?
No, but it looks like Christina Kitamura wants to say something.
Yes, she does. Yeah, go ahead, Christina.
It may not matter now since it's already listed in the materials for future discussion, but I was going to move Darlene Davis's comment to item 10 for suggestions for future agenda items. But if it's already noted to be discussed, I can just forgo that.
Yes. That's fine. Thank you so much. We can get a little technical at times, but I think it's important to put the comments in the appropriate, agenda items. So great. And so let's see. So there will be the, yes, so that would be the suggestions for future agenda items. I think we can officially open that one and see any public comments and any future agenda items from the board members. Susan?
You know, I feel very, very strongly that we must address the problem of online therapy sites that are advertising in California. We have no idea if they are plumbers or, you know, who knows who these people are who are advertising out there. We have no idea. So I think we have to come up with some kind of way that they have to register, at least with the board, and that we have some oversight of who the people are who are operating with that establishment.
Yeah. Well, thank you so much, Susan. I'm sure that that's taken by the staff. I think now we can move to Christy and talk about the the temporary practice allowances. So take it away, Christy.
Yes, I'm ready. Can you guys hear me okay? Because you're sounding choppy to me.
We can hear you very clearly.
You can, okay. I might, if you have questions for me, I might have to have you repeat them. It's a little choppy, so, but I will go ahead and present this item, discussion and comparison of the range of temporary practice allowances of other state agencies. So, as you know, they hold a current and valid California license if they're engaging in therapy via telehealth with a client physically located in California. At our last meeting, we talked about how many other states have a similar requirement, though some have more flexibility so that clients who are traveling or transitioning to living in a new state can obtain temporary services so that they have continuity of care from an out-of-state licensee. So we had provided a number of notable examples from other states at that prior meeting. So those are still included here in the packet. But what we did for this meeting is create a chart that kind of allows minutes of those laws in other states. So that's in attachment A. So if you on its things like how many days in a year can that person practice without being licensed in that state via telehealth? Do they have to disclose to the client? What are the circumstances under which they can provide therapy? Do they say this person has to practice or reside outside the state? In other words, you can't be licensed in one state and be living in the state that you're providing telehealth to a client that lives there. So I think that's to avoid, people trying to work the system a little bit. And then do you have to notify the board that you're seeing a client in their state? And then also I provided information about like what does their law say about what kind of license you have to have and where, like some specify the United States or Canada. Some are a little more open or flexible about that. So when we're, looking at maybe making some decisions, we can look at those components and see what we like or don't like. And then what I did was provide some examples of, so at the last meeting we talked about, let's maybe look at some of the more restrictive examples and some of the more flexible examples, and we can kind of compare and contrast and get some ideas from there. So I'm going to start with Arizona. They're one of the least restrictive. It's a very simple and straightforward exemption from licensure for therapists not licensed in Arizona providing telehealth services. So all it says is a therapist may provide behavioral health services in Arizona for no more than 90 days in one calendar year if they are authorized to perform those services by the state or country where they reside, and if they inform the client of the limited nature of the services and that they are not licensed in Arizona. So that's a very simple, straightforward. No, there's no other parameters surrounding that. The next least restrictive example it's more complex, but it's also very flexible. So it's the District of Columbia, and there's sort of several levels of this for telehealth by out-of-state practitioners. So that the first piece that they have is when there's an emergency situation. And this is general to health professionals, not just mental health therapists. So any health professional that is not licensed, registered, or certified in the District of Columbia, whether they're licensed or unlicensed in the other state, can provide treatment or advice in any case of emergency. They don't define emergency, nor do they specify any time limit. So that's just kind of a general piece that they have. The next component that they have, and 2 and 3 are related. One has to do with health professionals licensed in another state, but there's also this number 3 has to, if they're licensed in a state that adjoins DC. So, but the first one I'll talk about is you're not necessarily in an adjoining state. So, and again, they do this for all of their health professionals, not just mental health. So number 2, a health professional licensed in another state may provide care for a limited time in DC or provide professional consultation regarding a specific patient, provided these services are performed in affiliation with a comparable DC licensee. They don't put any time parameters other than to say a limited time. So that's not really defined, but to do any of this, that has to be in affiliation with a comparable DC licensee. And then that third component is if you are in a state that adjoins DC, you can provide telehealth services to a client in DC if they register with their board, the District of Columbia's board first, and pay a fee. So those are our 2 least restrictive examples. Do you want to stop there and talk about those, or do we want me to go on to our more restrictive examples next?
I think we can just go ahead and do that. Just share with, just talk about the.
Just keep going?
Just keep going.
Okay, sounds good. Okay, so we have 2 of the more restrictive examples of those states that we sampled. We have Utah. They allow an individual licensed in another U.S. state or territory to practice mental health therapy. They can provide short-term transitional mental health therapy remotely if all of the following are met. So the therapist has to be present in the state or territory where they're licensed to practice. So in other words, they can't live in Utah and hold a California license and see clients in Utah. It has to be telehealth and be located in a different state. If their client has relocated to Utah, is another thing that has to be met. The client has to have been a client of the therapist immediately before the client relocates to Utah. The therapist provides short-term transitional mental health therapy remotely only during the 45-day period beginning the day on which the client relocates. And within 10 days after the day on which the client relocates to Utah, the therapist provides written notice to the state of the therapist's intent to provide that therapy. And then the therapist does not engage in unlawful or unprofessional conduct. So that one has, a lot of provisions, but it's got a lot of protections as well. Avoids what could be seen as some loopholes. The next most restrictive example that we found is New Jersey. New Jersey allows a therapist who is certified or licensed in another state under requirements that their board considers equivalent to practice for a period not to exceed 10 consecutive business days or 15 business days in any 90-day period. The practitioner has to give the New Jersey board a minimum 10 days written notice of intention to practice, including a summary of their qualifications. So these are some examples of how some other states handle practice across state lines via telehealth, and so the committee may wish to discuss these requirements and maybe start looking at what components we want to consider if we're going to start developing a concept for California law.
All right. Christy, are you know, anything else you want to share before I open for the comments?
No, that's really all I had.
Okay, good. Because I was thinking that you might talk about that comparison, the very wonderful table that you put together, as the attachment A, that's, comparison of the different state. No, it's fine. I just want to, just give some kudos, for that very, beautiful chart, that table to capture, how the different states practice, based on, the number of years and client disclosure and all these things. It's a very, very, informative and very well organized table. So I just want to thank you for that.
Oh, thank you.
Yeah. So, so board members, so let's, discuss within ourselves. So, so are we, do we need to, so what are you guys' thoughts in terms of putting some guidance, for the clients, who temporarily move out of the states? Should we have some language, to govern that? If that, or put it this way, what kind of the clarification, or guidelines that we should provide for the, for the licensees and associates? Chris, I'm going to come to you first.
Thank you, Madam Chairman. No, I do think there should be some language. When I look at the different scenarios, or different conditions with which people are going to be out of the jurisdiction of California, for example, if somebody moves to a different state and we're treating them, I think that it's important that we maintain the ability to treat them until they found another person for the continuity of care. Or a student that's in college in another state, they may be there temporarily. I don't know if there's, if we need to look at how to work with that, or if someone's on vacation and they're having a meltdown and they need to talk to, their current mental health provider. So I think there's a lot of scenarios where, we need to be flexible with, being able to provide support. And I think that there's reciprocity to that too, with people that are coming to California and from other states and need to have access to their mental health provider. So I do think that we need to kind of be open now that we live in the virtual world where everyone is a click of a button away from one another. That it seems silly to block the mental health services of a consumer because they've crossed a line in the sand somewhere. But also to make sure that we're being respectful of the other states' rules and regulations. So I do think there's a lot of work we can do in this area.
Thanks, Chris. And Roseanne?
Yeah, I just want to clarify, for purposes of this discussion, we would be discussing allowing a temporary practice allowance for out-of-state practitioners licensed in other states for clients who came here temporarily. And like Chris said, it's a reciprocity thing. We can't really do anything about saying anything about what other states can permit, but we can control what we allow here, and then hopefully other states would follow suit.
Yes, so definitely. So, okay, so, any other board members' discussion? Okay, so moderator, let's move to open the public comments part of it.
All right, this is the moderator. We've opened the Q&A panel. And if you'd like to make a public comment, please click on that Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to all panelists. And we will pause for a moment, and it looks like Jennifer Alley will be our first commenter. Jennifer, your line is open. You will have 3 minutes.
Good afternoon. This is Jennifer Alley with CAMPT. Thank you again. That was a wonderful background provided by BBS, and that chart is very helpful. So CAMPT is in support, the California Association of Marriage and Family Therapists is in support of some kind of temporary flexibility for the continuity of care for, you know, people coming to California to continue their treatment, but also, you know, process and ensure that the conversation starts to allow the new resident to transition to a California provider. And so we are definitely open for continuity of care. I think this question came up a lot when, you know, students came home, you know, due to COVID, or were here temporarily to help with family. And every day, you know, camp gets calls about, you know, clients being out of town for a period of time. And again, you know, I know this isn't exactly the agenda item, but we do think that some clarity and guidance needs to be provided to California practitioners when they're practicing out of states. And so those comments are similar. You know, the questions are the same. So when, you know, a therapist from out of state sees, you know, observes child abuse, do they report it to California authorities or do they report it to state? And so we think there seems to be some sort of rubric established, some guidelines for therapists that would be practicing in California on what the board would want to ensure, you know, the best care and good clinical outcomes for the patients that they're treating that reside here. So that is all I have. Thank you.
Thank you so much, Jen. So looks like we have another comment, moderator.
Yes. Rebecca Gonzalez. Rebecca, your line is open and you will have 3 minutes.
Thank you. Rebecca Gonzalez, National Association of Social Workers, California chapter. During the pandemic, I must say this was by far the number one question we were getting was out-of-state therapist whose client had temporarily relocated to California. And I do think it was college students. So I thought it was interesting in the, let's see, which law was it? It was in the, I think it was in the District of Columbia law that talked about a state of emergency, although they didn't really define it real clearly. I mean, they could have said a declared state of emergency by the governor or whatever, but it does seem like it would be helpful to have something like that in our law. Although maybe when hopefully a pandemic does not reoccur, but if we have another pandemic, the governor and the state would be able to pivot really quickly to a waiver, but it still might be helpful to have something in our law to talk about a state of emergency and providing that flexibility. And I agree with Jennifer that we do think some kind of, in normal situations, it does make sense to have some continuity of care and some allowable provision for temporary treatment. Thank you.
Thank you, Rebecca. So let's see.
That looks like that's it.
That's it. Very good. Thank you, moderator. So, you know, I think we are very much in line with each other this time. It's like, you know, we should really allow some flexibility. And yet then the question becomes like, you know, how much flexibility? You know, do we go with, you know, the most restrictive or the least restrictive? And because, you know, in, you know, the chart, you know, that's the attachment A, actually, you know, really break down to the things that we have to consider. And so it would be about like, you know, do we limit that the number of days in years? Do we require client disclosure? Do we require, you know, the therapist, you know, may only provide, you know, therapy in a certain circumstances, you know, that kind of stuff. So I think, you know, we probably, you know, as committee, you know, we can really start looking at our preference. You know, what do you think? You know, that, you know, should we go to the most restrictive, the middle of the road, or just let the floodgate open, right? And so, what's you guys' thoughts? Oh, Chris, I'm gonna come back to you first, since you are the licensed person. Yeah, sorry that I have to pick on you.
No, it's okay. It's my first committee meeting, so I'm feeling the love here, Christina. You know what, I kind of live in the middle. I'm not really about being the most restrictive. I do think that we need to have some guidelines. But I think the middle is usually a good place to go, because I think that's where the most people are best served, where we still maintain some control over over the quality of, or not quality of service, but the parameters of service that are being delivered. So I'm not opposed to to a time limit, whether it be 45, 60 days, something like that, and having some sort of registration, maybe not registration, but just alerting us that there's other people practicing, so that we have it on record of what's going on. So just so that there's some sort of log. I'm sure Steve's shaking his head, going, "Oh man, that that paperwork to me involved in that." But just some accountability. I think that we need to kind of know what's going on in our backyard, but still allowing our the people that need the support to get it.
Thank you, Chris. So for myself, I like to, I do like some parameters, and that I don't know if I'm going to be, one of the more restrictive one, but I do think that, if the intent, is for the people, for the, for the clients, for those clients who are just temporarily, in California. And I actually, then I think we need to put some sort of clarification. And what I really like about this, the Utah one say that, specifically saying that person must have been a client immediately before relocating. And then also only allow the short-term transitional therapy or some sort of like emergency service, something like that. But I think to me, the most important thing is that, that we allow them to, we are addressing the continuation of care issue. And so when we put that parameter on, then we're not going to open the gates for, people, that, for say like, some provider that, that they can just open in California and say, oh, I provide short-term therapy. Because like a 90 days, you can actually take on a lot of the clients, And so I think, that is, that I would love to have to see the language, in the, in our, in our regulations. So that, and then I think, once we set that parameters, then whether it's, 45 days, 30 days, 60 days, I think that we, it becomes, a little bit less important, because we need to just basically knowing that this is a real transitional care. So that's my take. So Susan, any thought from you? So Susan, can you unmute yourself, please?
Sorry, I thought I was unmuted. As I represent the public, I'm going to speak from the perspective of the client, for whom I think there should be great flexibility because of situations like a pandemic or like a sickness. Let's say the client becomes physically sick and has to go home from college or something like that, or whatever, whatever it is. I think we have to retain flexibility for the clients. I think that as far as issues that I think some of the public brought up about, for example, suppose as a practitioner, you're in another state and observe child abuse, and you call that state's Department of Children and Family Services or whatever it is, I think they would be the ones that would give you guidance. They would either say, thank you for reporting this, and can you do this, 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 and this, or they would say, can you report that to your state? But they never would say that. I mean, if a California practitioner is in Michigan, I assume the Michigan department is going to want to know about that from a California practitioner. So I think a lot of those things are kind of like common sense what would happen. And I don't think you need to think about writing legislation that covers that. But as far as the clients are concerned, I think it's got to remain flexible, and that they have to be able to know that it's going to be flexible and that they're not going to be locked into a situation in one area.
Christina, you're muted.
Thank you. It's my turn. So I think that that continuation of care, like Susan talked about, is actually very important. So what we're really trying to balance is also give some clarity. When provider comes into California, or they're located in different states, and how things should be managed. And I think that certainly warrant a lot of other discussion down the road too. But thanks, Susan, for your comments. So I am thinking that so Christy, so where would you like to have some more specific, even more specific direction, or do you think the discussion is enough for now?
I feel like I've got enough to maybe give a first stab at it. Roseanne, what do you think? You think?
Yeah, I think that there's enough that we can draft something, and then that we can have a discussion about the features. Whatever we draft, what the features are that we like as a committee, particularly likes or doesn't like.
Yeah. Yeah, so we can bring that back next time with a little more concrete direction.
Right. So, so in that sense, I think, at least when we have some language, and we can also go from there and continue to discuss. So, well, thank you so much, Christy. And
thank you.
Yeah, this is wonderful. And so, so I'm going to close this discussion item. So I need to backtrack, because I actually made a mistake or omission to forget checking for the public about the future agenda items. So I'm going to go back to that segment of it. And, so moderator, you know me so well. I see that you already opened the panel.
It is open. If you'd like to make a comment or a suggestion for a future agenda item, please click on the Q&A icon on your screen. Type "I would like to make a comment" into that text field and submit that to all panelists. And we will pause for just a moment. And I'm not seeing any requests.
Wonderful. Thank you so much, moderator. So at this time, I think we come to the very last and a lot of our favorite agenda item, which is called the adjournment. So the time is 12:23 p.m. and we will close the licensing. We will close the telehealth committee, and we will be back 1 o'clock.
You're not going to races?
What's that? Oh, sorry. So yeah, so we will be back, at 1 o'clock. We will have the licensing committee and happen at 1 o'clock. So feel free to join us, and we will see you soon. And thank you so much for coming for the meeting. Bye, everyone.